Santa Clara Valley Medical Center is
All right then. Thank you all, ladies and gentlemen, for joining us this afternoon. It is 2 o'clock. This is the County of Santa Clara's Health and Hospital Committee. First item of business is the call to order, so we'll turn to the clerk and ask the clerk to call the roll and establish the presence of a quorum.
Good afternoon. Vice Chairperson Ellenberg.
Here.
And Chairperson Simidian.
Here.
Thank you. You have a quorum.
Thank you. Both members of the committee are present and accounted for. That takes us to item number 2, which is public comment. Public comment, of course, is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of our committee. We do have 2 cards today under public comment. One is from Mr. Scott Largent, and the other from Mr. Leonard Williams. So let me ask the 2 of them to please come forward. Thank you.
Good afternoon, everybody. My name is Leonard Williams, and I'm with Valley Medical Center. I'm also with the Patient Family Advisory Team. I want to thank you for having us here today. I want to talk a little about what happened on the 2nd of November, which I am a very staunch supporter of now. It's called the Heroes Run, and this really helps our children. I know that everybody's busy and can't get out there, but we had no representation there this year. Usually we have somebody from the board, has time to come out on a Saturday for a couple hours, meet with the kids, meet with the public and everything. We had a wonderful run this year. I worked from 8 to 12. We had a hero come in, and the kids were all wondering who was the hero. Well, they used a armored car that they parked on the side, and when the car came around, it was Spider-Man, and the kids went crazy. So when they got there, Spider-Man jumps off the top. He's standing way up there. He jumps off the top, gets out, and he runs the track with the kids. Now, the kids have their own track, their own thing. And I really enjoy it. I'm going to do it every year I can. I think it's a great opportunity to meet people. You also see a lot of things out there that people never see, diseases that they don't know that are out there. And we learn a lot. So like I said, every year we've always had somebody out there to go around, or, one year we had Bonita actually, she didn't run, she walked. She said, I can't run, so she walked it. So it's a great opportunity to meet people, to talk to constituents, to see what the kids do, to see what the different things they learn. They learn CPR, they learn a lot of nice things. So I really enjoyed it. And I hope next year is going to be bigger. I hope we get better publicity out there and get the people to come and really enjoy a great day. Thank you.
Thank you. Mr. Williams, before you step away.
Mr. Williams.
Hang on, Mr. Williams. I think Supervisor Ellenberg has a question.
Yeah.
Where was the run?
It's in Cupertino behind City Hall, by the library. And it was great. I mean, like I said, the kids they go crazy. They see the hero, the sirens go off, and they just love it.
Thank you so much.
I hope next year somebody could come out there and represent the hospital or the clinics. So thank you so much.
Thank you. And our next speaker is Mr. Largent. Scott Largent, you're up next, sir.
Thank you, Dave. Good afternoon, everyone. Scott Largent. I was fumbling through some documents back there, trying to navigate the system in a way kind of after the fact. I'm not sure if some of you are probably aware, this is a bus pass you can get when you're poor and suffering in our community. It's a 3-month pass. You can transfer from the light rail. Very, very, very helpful. I only found out about this thing 6 months ago. No one told me about this in the beginning of my sobriety. I was paying to take the bus. I didn't understand that you could transfer between buses. I just didn't understand any of that. I had a car in a previous life. I never had to deal with that stuff. This would be helpful. Other homeless people that are suffering in our community, they don't know about this type of stuff. So maybe when they come in here or they ask for services, this could be like the first thing that they might want to know about. Very, very helpful. When you're on EBT, and I went on food stamps and EBT about 3 years ago, and now I've done it again, you can get fee waivers for court when you're on assistance like this. A lot of people don't understand that. It's probably helpful to know you get a $500 fee waiver if you want to sue the city or the county that took your property. You have the option of doing that. So these are other helpful things. Another interesting one, because about 2 weeks ago, because I've been up and down, you know, I'm still sober, but I had to go apply for food stamps at the General Assistance Office. I had to ride my bike all the way out there. You know, my bike's kind of a junker bike, but it's all I have. So I take the bike all the way out there. Somebody stole my lock about a month ago. So I bring that bike out there, I kind of wheel it into the lobby, and I get immediately hassled. They're telling me you can't bring bikes in. And, you know, I do understand fire codes and stacking all these bikes everywhere. We did kind of work that out over there. A gentleman that kind of runs your social services gig for a lot of the construction, maintenance, and kind of the supervisor, Steve Fonadero, or I'm butchering his name, but the guy's a great guy. He went ahead and purchased 50 locks. You know, he started figuring out ways, how do we not let people get hassled down at the GA office over, it was pretty stupid, it's over a bike lock. I just can't lose my bike. Another gal there was very helpful. She knew that I had dental issues. I don't have teeth. And the dentures that the county provided just didn't cut it. It's like a hockey puck in my mouth. This woman told me about the Department of Rehabilitation, the fact that I have a learning disability and other disabilities, that they could help me get dental implants. You know, I've been going on 3 years. You know, if I can smile again, I could go get a normal job like I used to have. That'd be very helpful. And even at the University of Pacific School of Dentistry, they also take Medicaid and Medi-Cal to help people like myself. So these are all these little things that we're just not telling people about. And this would be very helpful. I could have used a lot of this stuff out the gates. So thank you.
Thank you. Supervisor Ellenberg, that takes us to item number 3, which is to approve the consent calendar and any changes to the committee agenda. I do know that we have a number of items 9 through 19 that were on our proposed consent calendar. Item 11, however, needs to be continued to our next meeting because we don't yet have a committee meeting scheduled for the coming year to approve. But otherwise, if you're prepared to offer a motion in support of the consent calendar as contained in our published agenda, with the exception of item number 11, this would be the time.
So moved.
We have a motion, and let me just confirm with the clerk, we have no cards on the consent calendar. We do not. So I will say a second. Without objection, unanimously approved. Thank you very much. That takes us to the first item of business on our regular agenda, items for discussion, and that is item number 4. And item number 4 is to consider the recommendations relating to medical staff and allied health professionals at the Santa Clara Valley Medical Center, O'Connor Hospital, and St. Louis Regional Hospital. And with us to present is...
Hi, my name is Yvonne Karanis, and I am the Enterprise President of the Medical Staff. I'm here to present the credentials report and answer any questions if you have them. I also would just like to add that I was at the Heroes Run, and I did represent the hospital and the medical staff, and it was a wonderful occasion. And also wanted to give you an update that the medical staff has been working hard on updating the bylaws to incorporate the acquisition of O'Connor and St. Louis Hospital. We have been doing the same with our peer review policies and also with our privileging forms.
Great. Thank you for all of that. Confirm again with the clerk that there are no speakers on this item. There are not. So a motion to approve the recommended actions A through C on item 4 would be appropriate at this time.
So moved.
Motion by Supervisor Ellenberg. Any comments or questions? There are not. Then we will say without objection and hearing none, unanimously approved. Thank you for being with us.
Thank you.
And next time wear your cape so that you stand out a little bit more at the Heroes Run, all right?
Thank you.
Thank you. Seriously, thank you for your participation. All right, that then takes us to item number 5. This is a report from the Public Health Department, and it is in connection with the Better Health Pharmacy. And I guess we start with you, Dr. Cody, yes?
Good afternoon, President Simidian, Supervisor Ellenberg. I want to invite my colleagues Jennifer Yoon and Nari Singh up to the staff table. We don't have a slideshow to go with this report. I'll just make a few opening comments, and then Nari and Jennifer will be able to answer questions. As you know, our Better Health Pharmacy has been in operation for 4 years now. I think it's since August 2015. And we provide prescriptions at no cost from donated pharmaceuticals, mostly from skilled nursing facilities. And it's staffed by 2 pharmacists and 2 pharmacy techs. So Jennifer Yoon is the director of the Public Health Pharmacy. Nari Singh is the director of Health and Hospital System Pharmacy, and both of them have worked for a very long time to make Better Health Pharmacy what it is. So we're happy to answer questions.
Thank you. Supervisor Ellenberg.
Thank you. By all accounts, this is really a tremendous program and service. Is there consideration of opening additional locations throughout the county to provide better access to folks?
And if, when you respond, you just reintroduce yourself to the committee and to folks who may be listening or watching as we stream.
Can you guys hear me?
Yes.
There you go.
Good afternoon. My name is Nari Singh. I'm the Director of Pharmacy at the County of Santa Clara. To your point, absolutely. The Better Health Pharmacy has been one of the hidden gems of the county. We do keep an eye on the number of patients who are using the pharmacy, the type of medications that they are seeking and they are looking for. So from a expansion standpoint, we can definitely take a look into where our needs are and what other locations we may want to go for. But as of now, the pharmacy is staffed by 2 pharmacists and 2 technicians. We are planning on trying to expand the number of prescriptions that are being dispensed from this pharmacy every year. And as you can see from Dr. Cody's report, it has been growing double digits. So we do keep an eye on making sure that the value to the community exists within the pharmacy.
Do you know, is there a way to track what the unmet need is? Do you know if you're providing all of the services that are needed at this point?
Not without doing some kind of a search or some research or analysis. About a year ago, the number of patients who used to come to us asking for inhalers, for example, was very high. And so we were able to work with Serum, one of our vendors who we have a contract with, to try to get that specific type of drugs into our pharmacy, and we were actually pretty successful. So at this point, the only way we can find a gap or find a unmet need is for the patients who come to the pharmacy asking for specific medications.
And if their doctors are prescribing medications, they have to come to specifically and physically to the pharmacy location to pick those up?
The patients?
Yes.
That is correct. Right now, we do not have the mail-out option yet. And one of the reasons behind it is we, in order to meet the Board of Pharmacy's requirements, which are pretty strict in this program,
One would hope.
we do it as one fill only. And so we do not honor refills. We do not honor controlled substances or opioids. The patient does have to come to the pharmacy to pick up their prescriptions.
Supervisor Ellenberg, I don't. Are you aware of my history with this program?
No, but I sense I'm about to hear it.
Well, I want to give you the, if only you had said that with more enthusiasm and less trepidation, Supervisor. Let me give you the very short version and then follow up. I deliberately leaned back rather than in on this one because of my history, but I'm about to lean back in, as you can tell. In 2005 or 2006, when I was in my first term in the California State Senate, had a group of Stanford medical students who approached me through what was then called There Ought to Be a Law contest. And they were familiar with drug redistribution programs in other jurisdictions, other states around the country, and suggested that such a thing might make sense for California. And curiously enough, Oklahoma was a leader in this particular effort. Never quite sure why that was sort of one of the places where the effort got traction. And I have to say, initially, I was not terribly enthusiastic because the sort of the phrase recycled drugs just didn't capture my imagination or enthusiasm. But ultimately, I was persuaded that it made a lot of sense. The reason I chuckled because of the Board of Pharmacy is the Board of Pharmacy it takes the view that notwithstanding the obvious benefits to people who are recipients, the obvious benefits actually to people who donate, because this is a relatively easy way for them to donate compared to the very rigorous regimen for drug disposal that's otherwise required. And notwithstanding the benefits to the environment, because frankly we know that a lot of people just either incinerate this stuff or toss it down the toilet or the sink and it ends up in the water system. The Board of Pharmacy's view is that their job is to keep one pill in the state of 40 million people from going awry, and so everything they do is about being tougher and tighter and limiting the possibilities for expansion of the program. So the initial legislation back in 2005-06 was pretty tightly crafted, I would say, very limited both in terms of sources of drugs, who could be the recipients of drugs, under what circumstances the drugs could be made available. And then several years later, in talking with a local nonprofit who you heard referenced called Serum, the group that is at Stanford, the students and graduates there who were part of this nonprofit to actually collect the drugs and then redirect them, or as one of them called it, the Match.com of prescription drugs, said, you know, we could do so much more if there were some changes in the law. And so those changes in the law got made 2010, 11, 12 in that time period, again, with a lot of pushback from the Board of Pharmacy. And I'll spare you that long story / diatribe. But I think it's fair to say, and I think our team would tell you that we're in a much better place today than we were before the updated law, that we have the ability to do much more. Now, notwithstanding that, my understanding is we're still really the only pharmacy in the state of California that's taken advantage of this option, even though Serum, the nonprofit, is shipping California drugs to other folks out of state. Do I have that right, Ms. Yun?
That is correct. San Francisco County called me and they actually visited our pharmacy. LA County did the same. Arrowhead County did the same. But none of them have opened the pharmacy yet.
Do you have some sense for what's keeping them from opening up?
In all reality, I think they're worried about the Board of Pharmacy. Because the Board of Pharmacy these days, not only they give a citation to the local pharmacist, they also give the citation to the pharmacist in charge. And people are worried. And then that fine shows up on the Board of Pharmacy's website for about 10 years. So it could impede in your future employment, so people worry about that.
Is the same administrator the head of the Board of Pharmacy today as was, say, 10 years ago?
So that administrator has changed,
Okay.
But now Board of Pharmacy is in bigger trouble because there is some cheating scandal that went with one of the exams. And this, again, I'll spare you the details, but they're in bad shape.
Got it. Well, let me say thanks, Dr. Cody, but also thanks to Paula Renz, who met with me and the team a couple of years ago in my office when we talked about the ability to grow the program in its existing location, and that was, at least in part, I think, the basis for growing the staff, which has been the basis for growing the level of distribution. Let me just ask Dr. Cody, Dr. Smith, Mr. Lorenz, if we have an interest in growing the program still more, what's the best pathway to pursue that conversation, whether it be more at the current location or whether it be with some additional locations? I see Dr. Smith leaning in.
Probably best to ask staff to come back with options for the board, you know, financial options as well as location options.
And would it make sense in your judgment if we made that ask as a committee today, ask that the item come back through committee before we then took it to the full board? I think it's
Sure.
premature to take it to the full board, but I think having some, if we were to give you that direction here, And I'll ask Supervisor Ellenberg if that's agreeable to her in a moment. But if so, both the potential for expansion there, and I, you know, as someone who represents the northwest portion of the county, I'm guessing a relatively small number of the folks who take advantage of the existing service are from my district, but I'm just glad that we're, you know, not seeing those drugs go to waste and that people are not having to incur the costs that they do would otherwise. So, but if we could talk about both expanding in the current location and then also look at the potential for other locations. I'm thinking particularly about our community clinics and whether or not there's a way to tie them in, not only those that are affiliated with our county, but our partners out there as well. So Supervisor Ellenberg, your thoughts?
I would support a request for a report back, but want to make clear that, at least from my perspective, it's not a mandate to expand, but simply coming back with information as to whether you recommend, first of all, an expansion, and if not, why not? And then if you do, then moving on to options. But I don't want us to make the presumption that it should be and can be expanded at this time.
Nor would I.
Right?
Just
okay.
Yeah. So,
but I would think South County, if we're talking geography, St. Louis is probably the place that makes sense from this lay outside point of view.
Okay. So I'm going to call that a motion, if I may, directing staff to report back with options and recommendations for possible expansion of the program, including cost implications and notions about where opportunities may best exist in our county. Is that
Glad to make that motion.
okay? Dr. Cody, does that work for you in that language?
That's perfect.
Ms. Lorenz, anything you want to chime in on there? Okay. Thanks again to you and to the team. I know we started out, I thought, thoughtfully and with some understanding that we wanted to make sure we knew what we were doing. And I think once people felt like, okay, we're clear, we've got our legs, the growth is really quite commendable. And, we don't need to revisit the painful stories of folks who forego their drugs because of cost. So, Dr. Smith, anything else, or should we just take the motion? I'll second and without objection. No, we're good. All right, then without objection, so ordered. And we'll say thank you again for the effort to date. And without providing direction, I'm not precluded from saying I look forward to the opportunities to expand the program in the future. All right, thank you very much. All right, that takes us to item number 6, and we do have one card from a member of the public who would like to speak on this item. And this, of course, is the annual report from Behavioral Health Services Department relating to the suicide prevention program. Who's going to start off here?
You want me to start off or public comment?
Mr. Larson, why don't you come forward? You are our one card, at least at the moment, so if you'd like to share your thoughts, and then we'll go to the report, if that works for you.
Sounds great. Thank you, Joe. Yeah, I thought you were calling me up here to go before the report.
Either way, all good.
Either way, it works out great. I attended a course that they had at your location out there at the behavioral health location for suicide prevention. And it was a neat course that I was able, it was free to the public, and Robert Aguirre, a homeless advocate, had told me about it. So I was actually quite impressed with that. I'd love to take some more of those courses because I do interact with the homeless a lot, and they're a segment that I want to make sure that this applies to also. The gals you had in there doing that course, I was impressed with just their background. The fact that they had struggled in the past, they had kind of pulled themselves up out of poverty, even things from drug addiction, even having suicide, something happening in the family. I enjoy interacting with people that understand. And I do. I know I'm a strong critic of behavioral health, but you got the right people doing that right there, Tony. So, again, thank you, everyone.
Thank you. Ms. Tullies, are you going to walk us through this conversation?
I'm going to introduce you to Mega Lynn, who is our suicide prevention manager. Delighted to have her here at the dais, and she'll be bringing a summary of our suicide prevention outcomes for the last year, and then answer any questions you may have.
Great. Welcome, and if you'd reintroduce yourself one more time, loud and clear into a working microphone.
Hello. Great. Good afternoon. My name is Meg Lien. I'm the Suicide Prevention Manager with the Behavioral Health Services Department. The reporting period for this report covers January 2018 through June 2019. And in this brief report, I'm going to share as well some updated data from the past few months. Hopefully this works. Okay. This is coroner's data on suicide deaths by county residents that occurred in the county. We did see a slight decrease in the number and in the rate of suicides over 3 years, starting from 2014 to 2017. The rate in 2017 on the right over there of 6.95 per 100,000 people was actually a 10-year low for the suicide rate for the county. A state report recently also found that Santa Clara County had the lowest suicide rate compared with other counties in the state between 2015 and 2017. That was a rate of 7.5 per 100,000 for the county compared with a rate of 10.7 per 100,000 in the state. So these lower rates definitely cannot be attributed solely to the work of this program. There are so many contributing factors to suicide, and prevention really does require a community-wide effort, and there still is a lot of work to be done. The suicide prevention program tries to impact some of the main risk factors for suicide, which you can see here, and I'm going to share just some highlights from the reporting period from our work on these objectives. We have a robust training program, as was just mentioned, for community members as well as for providers. And in this reporting period, we trained 5,355 people, and we've been working to improve the evaluation of our program activities. One thing we did when it comes to the trainings is we started asking the same evaluation questions across all of the trainings that we offer that are related. This was going to allow us to look at the overall impact of our trainings efforts and compare the effectiveness of individual trainings. So the measures you see here ask about people's knowledge and attitudes around suicide, how confident and prepared they feel to support someone who's in suicidal distress, and cultural competency. People answer these questions on a scale of 1 for strongly disagree to 5 for strongly agree. And you can see for the measures pre-training, which is in yellow, people on average disagreed or were not sure how knowledgeable or confident they felt about these skills. Post-training, which is in green, the averages rose to about a 4 for agree or higher. And then the blue on the very right-hand side shows that we ran statistical tests and found that the averages were statistically significant, or just not due to random chance.
Excuse the interruption, but since you mentioned statistical significance, the statistical significance that you just referenced is in connection with the training?
The change of the averages from pre-training to post-training.
Let me ask then, and again, I apologize, but since you've referenced the issue of statistical significance, in the very first slide you showed what you characterized, I think, as a relatively small drop. Is that drop deemed to be statistically significant?
We didn't test the drop to be statistically significant. It's something we could do. Traditionally in suicide epidemiology, folks look at trends over a 10-year period to really make a conclusive statement that the rates have been dropping. So it was encouraging for us to see this slight drop over 3 years, but we wouldn't make any really strong conclusions based on this.
Thank you, and I apologize for taking you off track.
No problem. Okay, so one area I will point out at the bottom here that we would like to work on is the cultural competency part. So you can see that the increases did not apply for the last 2 cultural competency measures. And we've been working in partnership with Palo Alto University to update our training content to be more culturally competent. The crisis text line for the county, this was launched in December 2018, and we ran a couple of campaigns to get the word out about this service. So anybody can text the word renew to the number 741-741 to access a crisis counselor by text message. As of last week, we had 497 conversations that had taken place under this code word, and the graph on the right tracks the volume of text conversations over time. We did see a spike in the volume of text conversations in August, and our work groups think this is attributed to the shooting that happened at the Gilroy Garlic Festival. In terms of demographics of who's using the service, about 80% are under age 35, as you can see there, and 37% of them are under age 18. Half identify as Hispanic Latinx, 65% as LGBTQ+, and then nearly a third report having ADD or ADHD, or being 9% being hard of hearing. So it really is a diverse group, and we also found that more than half of the texters shared something with a crisis counselor that they'd never shared with anybody else. In 2018-19, we started a school-based partnership for suicide prevention, essentially supporting school districts to implement suicide prevention policies, and this is under state policy AB 2246. All of the participating districts begin by training all of their teachers and staff in the online simulation training, Cognito. That's a screenshot you can see there on the slide. And districts concurrently work on their crisis protocols with the Herd Alliance team, which is out of Stanford, Palo Alto. In the first year, we had 7 districts participate, representing 86 schools and more than 55,000 students. They trained nearly 2,400 teachers and school staff in the Cognito simulation, and our program supported more in-depth trainings for school mental health professionals as well. So we're now in the second year of the partnership. We've expanded to 12 districts, plus 4 more that are in discussion. You can see the list of districts there on the slide. Last year's districts have moved on now to trainings in trauma-informed practice or trainings for students to provide peer-to-peer support. And we expect more districts to join, especially because the state recently passed another policy. I believe it's AB 1767, and this expands the original policy to cover grades K through 6 now. The original policy covered grades 7 through 12. We're still analyzing the data from year 1 of the partnership, so this is just one snapshot where, as a result of taking the Cognito training simulation online, about half to 2/3 of middle and high school teachers reported increases in the number of students they've recognized as having signs of psychological distress, as well as the number of students they've approached, discussed a referral with, or talked to other teachers or staff about their psychological distress. And these were surveys that were 3-month follow-up after the Cognito training. On the right there, in terms of the crisis protocols, one district said that they have caught kids earlier and have been able to intervene at crucial times in every one of our secondary schools. Another said that teachers feel empowered to deal with crises without having to rely on counselors and admin. So there's been growing interest in our work, and in the past year, we've put on 2 conferences on suicide prevention. In June, we partnered with the American Foundation for Suicide Prevention to bring their LGBTQ+ suicide prevention conference to South Bay for the first time. And then this past fiscal year, we were happy to receive additional annual funding from MHSA to hold an annual county suicide prevention conference. This is where the pictures are from. The first conference was held in May, which is Mental Health Awareness Month, in partnership with the County Office of Education. And we had about 150 people in attendance, both from the county and surrounding counties, plus a very long wait list. So the last highlight I'd like to share is from our work around older adults. We spent the past year testing and developing this particular suicide prevention campaign, and it aired July through October of this year, so it just went off air. You can see on the upper right that the campaign received millions of impressions through digital newspaper ads and YouTube ads. We placed them on YouTube under news and health channels, and then nearly 800,000 impressions through KCBS radio. We also had placements in local print newspapers and through partnerships with some community organizations, such as senior centers, the Diocese of San Jose, and libraries. The calls to action for the campaign were to call the crisis hotline or to access the website, which has more information about warning signs and local resources. Up there you can see the website received almost 12,700 visits during the campaign. And then below that, we compared calls to the crisis hotline with the same months last year when the campaign was not on air. We saw increases in August and September in the percentage of calls from age groups 55 plus, and we saw increases in July from the 55 to 64 and the 65 to 74 age groups. And in some of these cases, the percentage of calls almost doubled. So we were encouraged to see that. So I'll just end this presentation by showing you the video from the campaign, which features the story of a community member whose name is Benjamin.
Do you need some technical help on that?
It was working earlier.
Okay.
We tested
Let's get some help because it's home. Thank you.
I got badly injured at work. As a result of that, I lost my job. My fiance left. I had no more control over my life. I couldn't even roll over in bed, and everything hurt. I regained a sense of control by saying, I've had enough of this. I don't want to live anymore. This is the end. I saw no way out. I'm lying in bed.
Should I try the file?
And I'm starting to hear some music. I was absolutely mesmerized by it. It was beautiful. It opened my mind.
In just a moment, we're going to pull this up and figure this out.
Music was so essential to me, and I wanted to pursue it. That's when I knew I needed help. You know, I'm tough, I'm a man, you know, hear me roar. Find help. If I need to have my roof put on my house, I'm not going to do it myself. I call somebody who knows how to do it. You need to go to people who are dedicated to helping you. They're going to help you understand what's going on, why it's going on, and what tools you have to deal with it, and why it's important. But the why it's important is really up to you. I still deal with depression. I can feel it on a daily basis even. But the thing is now, I know what to do about it. And that's what good professional help can bring. I realized what brings me joy in life. Music, friends, going out to take a walk and feeling the sunshine. Recognizing that you have that problem, and then recognizing that you can do something about it. So you're regaining control. It's the first step.
Thank you. So I can take some questions now.
Thank you. Supervisor Ellenberg?
Thank you. That video is really powerful and well done. I want to thank you for the report and for all of the really critical work that's being done by the SPOC and the work groups. And I really appreciate the array of strategies that have been incorporated into this plan and the targeted approaches that you're taking with youth, older adults, and culturally specific groups across the county. As you know, I am very concerned about youth mental health and suicide prevention efforts and look forward to recommendations from the behavioral health in relation to my recent referral on school-based mental health resources and how that can align with some of the training and resources that are described in the report. With the very recent suicide of a Wilcox High School student. I'm wondering if you can tell me more about the current resources and supports that are provided to school communities, families, or friends by behavioral health or stakeholders in the SPOC after a death by suicide occurs?
Yes, so immediately after a suicide occurs, we connect our partners to grief support resources. There are a number of community organizations in the county that do provide this very well, such as Clara, which is located in Palo Alto and San Jose, the Bill Wilson Center for Living with Dying, and Community Solutions in South County. So these organizations will go out to a school site, for example, and hold and facilitate grief support groups for students or for staff. And, you know, CARA doesn't charge for this kind of service. At our program, we also offer support to school communities through our work with the Stanford and Hurt Alliance team. So they have their K-12 toolkit for mental health promotion and suicide prevention. One whole section of it includes resources and tools for response after a suicide for any school community, which are really helpful. For example, timelines for what to do day by day after the suicide, sample announcements for students and staff, sample agendas for a grief discussion with a student. And then longer term, one of our work groups has put together a grief support resource of what's available locally. For example, our suicide and crisis services team runs a weekly support group for suicide loss survivors. This is based in San Jose. And we've also piloted some bereavement counseling trainings for clinicians so that we can expand the capacity of this kind of support in the county.
That's great. Whose responsibility is it to initiate those services? Does the school district have to reach out, or when the county hears of a suicide, do we proactively reach out to the school district and say this is what's available?
It's a little bit of both. Through our school-based partnership, we've been fortunate to build some strong relationships with school districts. So in the case of the Wilcox high school student, I learned that through our connection at the school district. I also do receive the suicide death reports from the coroner's office and sit on the child death review team. So there are a number of other ways where I would learn about this. And sometimes I do my own sort of looking into whether there's a community organization that's attached to a particular suicide death, like a school community or a workplace that we can reach out to.
Thank you. To Tony, have suicide prevention policies and law enforcement training activities been considered as part of the scorecard and award criteria for the Healthy Cities Initiative?
I can't respond to that, all of that. I can say that what we're doing in the plan for suicide prevention, it is the strongest plan and really leading the way in California. And our work with CIT officers as well is another area where we've gone above and beyond what is required. Both the Sheriff's Office and the San Jose PD are not only doing the basic CIT training, they're doing the much longer CIT training, and they're mandating all of their officers to take that class and be ready for these situations when they're out in the field. And I'm not sure about the Healthy Cities Supervisor, but we can get back to you on that.
Okay, thank you.
We've done a little bit of
All right, hang on a second. Let me be the air traffic controller here. Let me turn first to Dr. Cody, then back to you, Ms. Leon, then back to you, Supervisor Ellenberg.
You might be thinking of the Healthy Cities Initiative in the Public Health Department, and it's focused, is that perhaps what you're thinking about?
I think that is.
And it's focused on policies around tobacco, healthy eating, and physical activity, and it doesn't expand to include suicide.
It does or does not?
Currently does not.
Ms. Leanne, anything you wanted to add to that?
So we've had some discussions with the Healthy Cities Initiative. Mostly these discussions were around preventing suicides by firearm. And so this coming year, they are interested in adding safe storage policies to their scorecard and dashboard. I have informed them about policies for suicide prevention and law enforcement training. So this is something they're interested in considering for a future year, possibly.
Thank you. I think that's a terrific suggestion and a piece that would certainly indicate, be an indicator of the wellness and health of a city. Is that something that might be considered?
There's a the Healthy Cities Initiative could expand or contract based on cities' interest and resources in public health and collectively in the county. So we could think about it. But again, right now it's fairly focused. I think it needs to expand. I don't know how broadly.
Okay, thank you, and perhaps led by the cities. I was interested in the report conclusions and recommendations where there was a reference to increasing outreach and training of clinicians on suicide prevention across the county health system. To date, what supports are being provided, and are there any additional plans in development?
I can answer. So we're partnered with Palo Alto University to pilot a 6-hour training with health system staff. We're going to be doing it 2 times this fiscal year. The name of the training is called Advancing Suicide Prevention and Clinical Management for Diverse Clientele. And the first one's actually taking place tomorrow. It's fully registered with 70 people, and we have a wait list of more than 70. I was pretty startled by the overwhelming response, happy about it though. So we plan to continue offering the training in future years. We've also partnered with some health system teams on outreach around suicide prevention and sharing our campaign materials like the Older Adults campaign video and the brochures attached to the campaign. And we're working with custody health staff regarding culturally competent suicide prevention and updating the suicide prevention training that the correctional officers have, I believe, every year or 2.
I'm really glad to hear all of that. Just one final question about that. The 70 people that are signed up, do you know the professional demographics? Is it doctors, nurses, social workers, other hospital staff?
We initially gave it out to behavioral health, mental health clinicians, but a number of medical doctors got wind about it and requested time off to be able to take the training.
Good. I would think the behavioral health people know the most about it, and it's all of the other providers that really need to, would I think most greatly benefit from that increased awareness. Thank you so much for all of this work. It's really impressive and important.
Thank you, Supervisor Ellenberg. Let me first add my thanks for the really going all out with the effort and for the good work. I wanted to cover some of the same ground Supervisor Ellenberg did, but since she has covered much of the ground about the program itself, I wanted to spend a little more time talking about our understanding of the problem and the challenge. And Supervisor Ellenberg, when we began the committee this year, I indicated I wanted to see if we could make this committee a useful forum for some conversation that perhaps hadn't taken place in the past. So I want to try that again today, understanding that this is a difficult and challenging subject, but I really do hope people will lean in and take part in the conversation, because I want to confront some issues here that are perplexing to me. And so while we've got the program in place, the program, of course, is the means to address the underlying challenge. And so I want to spend a little time talking about that underlying challenge. And I want to start with the fact that the data you've provided, if I read it correctly, indicates that while the number of suicides is down, the number of folks showing up in our emergency rooms with suicide attempts or suicide ideation has actually gone up during the same period of time. Did I read that data correctly?
It's not the same period of time as the deaths, but it's right before it.
So
yes.
So it is, notwithstanding a lack of absolute overlap in time, is it fair to say that the number of suicides has gone down, but the number of folks presenting at the emergency room has gone up, and either with attempts or ideation? I'm trying to square that circle and understand what the seemingly conflicting results might suggest.
Well, so just to clarify on the time period, so yes, the suicide attempts have gone up in the period of 2014 to 27, before 2014, sorry. And then the decrease in deaths was between 2014 to 2017. So they're sort of subsequent to each other.
So what do we make of that?
It's difficult to say, and our data work group has just started looking into the attempt data. There's been an effort for a number of years to try to link the attempts data to the deaths data, and just bottom line is it's extremely challenging. So what we're doing right now is working with the Public Health Department to try to look deeper into the attempts data itself to see if we can glean more information from that as to why the increase in attempts is happening. But again, without looking at the data, it's pretty difficult to say what that relationship is and what's driving it.
Well, I want to see if there are others who have comments or thoughts about that information, even if it's somewhat speculative or experiential, anecdotal. But I mean, it obviously caught my attention. Is attempts are, you would like to take some solace in the fact that the number of suicides is down. It's hard to take solace in the fact that the number of suicides is down if we've got more folks presenting at our emergency rooms who have either made an attempt or who are showing up with suicidal ideation. All right, let me take it a different place.
Well, I think one
please. Ms. Tully's, lean in, folks. This is.
I'll lean in.
Thank you.
I lean in.
Yes.
I think on this one that we're talking about the data we're looking at in our county and trying to do this crosswalk, working with our data committee, working with Palo Alto University. I don't have the data to share with you right now, but I know in our field there is a lot of discussion nationally around the increase in youth attempts towards suicide. And it's rampant all over the country. And it's something that the children's mental health people are paying a great deal of attention towards. So I think we've done a lot with the schools that you're hearing. But if you're asking for what's the global conversation, the conversation that my colleagues and I are having is this steady increase of youth who have attempted suicide. Now, we could look at our own data. We have data for our county, of course, but I'm talking about globally. People across the state are discussing it. People across the country are discussing it. And that doesn't give you the specifics you're asking for, but I will tell you that that's what we're looking at.
Well, I want to make this a specific request because as much as I appreciate the look at what we're doing in our county, and that's certainly appropriate and should be front and center in our conversation today, since this is a committee report about what's happening, what we're doing. I would like to get some feedback, and it could be in the next 2 weeks, the next 2 months, the next year. But I'm looking more for some serious thinking rather than an immediate response to check the box. Forgive me about. What do we make of this data that says, on the one hand, the number of suicides is down, on the other hand, the number of folks presenting is up? Dr. Smith, and I've got a few more of these, so but I'll turn to you if you have thoughts on this one before we lose the thread.
I think part of the disparity in numbers has to do with a few realities, and that is that a lot of people who ultimately commit a successful suicide, I know that's a bad word, it's not successful, but have deaths associated, have tried numerous times in the past. And that usually starts out with a pattern of intentional failures and then progresses to more dedicated attempts to actually kill oneself. And so that changes the ratio of attempts to deaths. Also, in recent time periods, particularly with young adults and kids, they have access to more lethal implements of self-destruction, not just guns, but very powerful drugs, trains, cars, lots of other things where you don't really get a second chance. And then the third thing that I think is also important is that due to our efforts to publicize the risk and to promote awareness. There are a lot more people who are aware of depression and pre-suicidal behaviors and get their friends and loved ones to services sooner than later, and so that decreases the number of attempts, not without necessarily decreasing the number of quote successful suicides.
Thank you. Let me take a look at a different set of issues. I noted that, if I remember the data again, Ms. Leanne, that Los Gatos was at the top of the list in terms of the per capita suicide rate. My recollection 4 or 5 years ago was that Los Gatos and Palo Alto were the top two in the county, if I'm remembering my data correctly. Prosperous communities, folks would describe them as privileged in many ways. That might seem counterintuitive to some. So to what, if anything, do we attribute the fact that those communities, this time the reference was just to Los Gatos, to be clear, unless I missed it, but I remember Palo Alto and Los Gatos were number 2 and number 1 in prior studies looking over a 5-year period of time. Do we think those numbers are statistically significant given the relatively, I mean, each one's a tragedy, but relatively modest numbers for statistical purposes, and particularly in those smaller towns? And if so, do people have either data or, again, experience, anecdote, speculation about why is it that in places where most people would think this is about as good as it gets, we're seeing these kinds of heartbreaking numbers?
Well, I think for Palo Alto, I believe it was for youth suicides where it had the highest rate. The Los Gatos rate was for suicides of all ages. And we've discussed this a bit in our team. And again, it's multiple factors. One of them could be that the population of older adults might be higher in Los Gatos. Our rate of older adult suicides is the highest when you look at other age groups in the county. Also, access to lethal means is another factor, a big risk factor for suicide. And Los Gatos, the firearm ownership in households tends to be higher when compared to other cities. So those were two of the things that did come up. Less conversation around.
Excuse me, Ms. Leanne, I just want to make sure I heard you correctly. Did you say that the number of households, sort of on a per capita basis, that had firearms was higher in Los Gatos?
Firearm ownership,
Thank you.
yes. And that's been associated with higher suicide rates. I mean, other factors, rural areas with more isolation are also associated with more higher suicide rates. So there are a number of factors that could go into this.
Also noteworthy to me was that if I read it right, the suicide rates are highest among the Caucasian population. Did I get that right?
Yes.
And appreciably higher among men than among women, yes?
Yes.
Which would make white men sort of doubly at risk, yes?
Yes.
And to what do we attribute that? I know that's not a phenomenon unique to Santa Clara County, so if you could share, and again, if others would like to lean in.
It's the case in the country, across the country as well. Again, firearms as a selection of method for suicide is brought up many times, where men are more likely to attempt suicide with firearm, which is basically 99% of the time going to be fatal when you attempt in this way, where females are more likely to attempt with methods like overdosing or poisoning, where there's more time to intervene and get to the emergency room. Some other factors that have been raised are, social norms around masculinity and males sort of being less likely and more reluctant to reach out for help or even to admit that there's a mental health concern going on with them. And one more is the expression of mental health distress or mental distress in males, where the expression may be more violent in how it is expressed when compared to females. Social networks as well, not having as much access to social networks or as robust social networks is another factor that's been studied.
Thank you. You anticipated my next question, which was that if I read the report correctly, that we had a higher that the deadly outcome was greater among men in their attempts than it was among women. Did I get that right? Is that a
Yes.
accurate characterization of the data? Okay.
Mm-hmm.
And do I gather from your last set of comments that that may in part be attributable to the use of firearms as a method of committing suicide?
Yes.
Any other thoughts on that?
Behind the selection?
Well, the fact that men are more likely to have a deadly outcome than women, apparently, who attempt.
I'm not sure about the evidence about selection of firearms, but just from an environmental standpoint, what's available and accessible around somebody is definitely a factor in suicide rates. And so I think it might just be associated with men being more likely to have firearms or to have firearms in the home passed down to them, to have experience using firearms growing up. And so just as a function of having them around in their environment, that could contribute to the higher selection of firearms for attempting suicide.
Okay. Slight change in subject. A decade ago or more, the California legislature took up the issue of what is sometimes referred to as death with dignity legislation. And it was controversial at the time. During my tenure in the legislation did not pass. As you know, within the last half dozen years, legislation has passed, and California now has what, again, some refer to as death with dignity statutes, among a minority of states that have such statutes, as I understand it. Do you have any thoughts about that in the context of this report?
I don't think I'm familiar with the details of the death with dignity policy.
Ms. Tully, Dr. Smith, the concern, of course, was that aid in dying, as it is also sometimes referred to, had the potential for abuse or misuse. And I just wonder if we have spent any time thinking about whether or not that has been the case, looking at data to see whether or not that has been the case.
Strangely, after the passage of the law in California, there was very little utilization of the law. And I don't know, and I'm sure other people know much better than I do, but I don't know if there's been any study about why. But I suspect it probably is related to the strong stance against the law that organized medicine took, and it requires physicians to be involved in the process. So it's a little hard to find a doctor who's willing to be involved. I don't know.
And in
Tony?
in the coroner suicide cases that I receive, I've never seen one of these cases, so I think they're classified differently from the data that you've seen.
Thanks. I think what I'd like to do is look to my own staff, and I've got two members of my team who are here in the chambers, and ask that we take this opportunity to take the 5 questions/issues I've raised and put them in a brief letter to you, Ms. Tullies and Ms. Leanne, and ask for some follow-up. And again, not anything that we need to get the next 2 weeks or even the next 2 months, but these are issues that your reporting sort of pushed to the front of my thinking about this subject. And I'd also like to ask that when we get the next report like this, that we spend a little more time focusing on sort of those kinds of issues. As I said, I very much, and Supervisor Ellenberg really said it, so if I give it short shrift, I apologize. But I mean, the work you're doing is extraordinary, and it's clear that people are going all out and making every effort, and I don't doubt for a minute that it's having an impact in saving lives. But I want to make sure that, at least as one member of the 5-member board and as the chair of this committee, that I understand the issue as well as it's possible to understand the issue from a layman's perspective. And these are questions that your reporting prompted in my thinking, and I want to pursue them with you as we go forward. Okay. Anything else you'd like to share at this point, Ms. Leanne, Ms. Tullies?
Well, I like to highlight excellence, and I think Mego and her team are the best suicide prevention leaders in California. I think we're really lucky to have them, and we just continue to provide funding. We're really focused on not just the populations, but the cultural component. I am, as the director, it's one of the things I'm proudest of, and I just think you've seen outstanding staff work. And I want to echo what you've already said, but put it in the minutes. Thank you.
Dr. Smith, anything else on this? No? Supervisor Ellenberg. All right, well then, Ms. Leanne, the only thing we were asked to do formally today is to receive the annual report. So I'm going to say, without objection and hearing none, the report is received. I think one of the rare times I can speak for other members of the board is when I get to say thank you for the good work again on behalf of the entire board and certainly the 2 members of this committee. And my office and I will be following up with you and your team on the other questions that were raised today.
Okay.
Thanks.
Thank you.
Tough work and important to have such high caliber effort on it. Thank you. That takes us to item number 7. And item number 7 is the report from the Santa Clara Valley Medical Center relating to operational imperatives, goals, and progress. And as folks take their place to speak to these issues, Supervisor Ellenberg, I remember the look on Dr. Smith's face when we were getting a report on these issues a year or 2 ago, and I leaned forward and said, hey, these all came from Dr. Smith, and we aren't making as much progress on them as he had asked us to make. What's going on? And so we're back having this conversation now. In part, Mr. Lawrence is smiling. He remembers that moment as well, to say, all right, how are we doing? And I couldn't help but smile at the fact that 4 goals apparently wasn't enough, so now we have 3 more to work, to strive towards achieving on. But who's going to present? Who'd like to begin?
So
Please.
if I may, Supervisor, President
Mr.
Smith,
Lawrence.
just briefly, and thank you for the introduction to the topic. And as you well pointed out, Valley Medical Center, along with Dr. Smith, came up what we consider to be performance improvement initiative that would have a significant impact financially on the system, but also improve access and quality and patient experience. So what I'd like to do now is introduce 4 individuals. While we have been obviously focused on the integration of 2 new hospitals, the team before you and many others have been focused consistently on these areas. So before you have Dr. Angela Suarez, who is our medical director for primary care. You have Serena Sai, who is our director of operations for primary care. Sanjay Karani, our medical director for Valley Medical Center, and George Harrell, who oversees our business development at Valley Medical Center. The 4 initiatives that you had mentioned are above you. They focus on non-acute care in both our medical patients in the hospital as well as our psychiatric patients, but also we're focused on primary care and outside healthcare costs. The other 2 initiatives, other initiatives that you had mentioned that we're also undertaking, which really do focus on not just Valley Medical Center, but on the system. Inclusive of course, O'Connor Hospital in St. Louis, and those are the ones that you see on the next slide. Perioperative services, inpatient lengths of stay, and specialty care. But with that being said, I'm going to turn it over to the team here, and they can walk you through the effort and the results.
Thank you. And again, let me ask people to reintroduce themselves as they begin to speak so we can make sure that everybody knows who's who. Thank you.
Hi, I'm Dr. Sanjay Karani. I'm the interim hospital medical director. Good afternoon, honorable board members, Supervisor Simidian, Supervisor Ellenberg, Dr. Smith. It's a pleasure to be here to report back on our work in reducing our non-acute medical patient census in the hospital. I had a chance to report on this subject last year. As you may recall, a non-acute medical patient is a patient who no longer meets medical necessity for acute hospitalization, but remains in the hospital because of other complex factors, such as underlying psychosocial issues, homelessness, dementia, and cognitive impairment, and substance abuse that limit our ability to discharge these patients safely out of the hospital. These are especially vulnerable patients with respect to their social determinants of health. Our CLT patient flow team recognized the impact these non-acute patients were having on our hospital capacity and thus affecting hospital flow. A deeper dive was done to look for solutions that address this issue, and I look forward to presenting to the board some strategies we have successfully employed to address this problem. The first was simply counting the number of non-acutes in the hospital, which is accomplished daily at our multidisciplinary rounds in the hospital, which involves clinicians and other ancillary staff members, case management, and so on. A dedicated long care management team works intensively on placement efforts, reaching out to community resources such as skilled nursing facilities. Understandably, many skilled nursing facilities are resistant to accept these non-acute patients due to their complex needs and lack of discharge plan. So as a result, we developed contracted agreements to lease skilled nursing facility beds and reserve beds for VMC at these nursing facilities. However, we understood that simply reserving beds in the community was only a piece of the solution. We developed a novel multidisciplinary support team that works directly at the nursing facility called our Post-Acute Care Transitions Team, or PACT. The PACT team is an integrative transitions of care program that provides a continuum of care between the hospital, the contracted skilled nursing facility, and links the patient to community resources and public agencies, such as the Office of Supportive Housing, Valley Homeless Health Care Program, Behavioral Health Services, Substance Use Treatment Services, and VMC Primary Care. The PACT team is comprised of a geriatrician that specializes in caring for the elderly who have behavioral disturbances and dementia, a hospitalist who works both in the hospital and at the contracted skilled nursing facility, thus providing continuity of care. And the team has care management, social work support, and an LVN who are critical in helping these patients get discharged from the skilled nursing facility and re-enter the community. Next slide. We first started keeping close track of our non-acutes 3 years ago when the non-acute daily census was 36, although prior to those numbers that you see here, we had been high as 50 in the past. And understanding that our adult census can run between 150 to 200, that's a large, significant portion of our acute hospital beds. Using the strategies we discussed, we've seen year-over-year declines in the non-acute adult census to about a drop of nearly 61% since 2017. Next slide. And over the past year, we've made some of our greatest improvements and reached our goal of a non-acute census of less than 3.5%. Yesterday, our non-acute number was 3. Now, when you compare that to 50, it's quite a reduction. Furthermore, next slide, our length of stay of non-acute patients within the hospital has dropped by 47% since last year. Some of these patients can stay months. We've been able to drop that by almost half. The extra capacity has had positive effects on our ability to provide acute care access to our patients, both from the emergency department and high level of care that are coming from throughout the enterprise. Next slide. Given the problem of non-acutes is ubiquitous and affects all hospitals, we decided to share our story of the PACT team and its success. Out of a large field of both public and private hospitals, we were recently recognized by the Hospital Quality Institute with their top award, the 2019 C. Dwayne Donner Quality Award. And there you go. We would like to share
Santa
this
Clara
video
Valley
with
Medical Center is the safety net hospital of Silicon Valley, of all of Santa Clara County. And what was happening is the hospital was getting overcrowded. And when the hospital gets overcrowded, the ER gets overcrowded. We can't just move these patients out while they're still sick and try to get them out. And as we did a deep
Can I jump in?
Please.
While we're talking. The committee and the public are going to hear the great stories behind all 6 of these efforts, but I'll be quiet.
Santa Clara Valley Medical Center is the safety net hospital of Silicon Valley, of all of Santa Clara County. And what was happening is the hospital was getting overcrowded. And when the hospital gets overcrowded, the ER gets overcrowded. We can't just move these patients out while they're still sick and try to get them out. And as we did a deeper dive, what we recognized is the reason why we were overcrowded is there were a lot of patients that we had that were simply non-acute, sitting in the hospital.
Oftentimes those patients can be in the hospital and not have an acute medical need to be there, but they can't be safely discharged to the streets.
One of the hospitalists over here, one of our mentors told us that the most dangerous thing you could do for a patient is to discharge them. And with good reason, because in the hospital they're monitored, but once you discharge them, you have no idea what happened. A significant number of them, unfortunately, are homeless. They have very complex medical conditions.
So we had to come up with our own bold solution on how to care for these patients.
We thought, well, what would be the ideal transitions model for these patients? And so a number of them, ideally what they would need is a full multidisciplinary team to help them with medications, to help them with mental health issues.
We just kind of flew by the seat of our pants and adapted and learned and changed as we saw fit. It goes back out to going beyond the walls, you know, breaking down the silos, talking to individuals that I would have never talked to. It involves case managers, social workers, psychiatrists, psychologists. It involves so many different departments.
They don't have the physical or the social supports that a lot of us take for granted.
Essentially that was our compass, was what can we do to take care of the patient?
Overall, from a holistic standpoint, it's been an incredible success for us.
Every hospital, private or public, encounters this problem, and that's why we want to develop something that can hopefully be replicated by others. We want to share the secret.
It's incredibly fulfilling, gratifying, as a provider to be able to affect someone on such a deep and personal level, and to see the outcomes that we can achieve.
So that's the team right there. I asked them to join us, but they're at the nursing facility right now, so doing hard work. So, but that's the true heroes right there who are doing hard work right now for the team. I'll take it to slide 6. Or excuse me, the next slide. Thank you. So given the non-acute patients have high complexity scores and can be high utilizers of the system, we would expect a readmission rate of at least 20%. Our readmission rate of the non-acute patients cared by the PAC team is around 5%. This has helped us lower our aggregate hospital and readmission rate to 16%, which is below the regional and national averages. But I think the major cause for the reduction in overall hospital readmission rate is due to the improved capacity of primary care, which allows early follow-up of hospital discharged patients and mitigates the risk of admission. And this will be discussed further in our presentation by Dr. Suarez and Serena. In terms of next steps, we hit our target of 3.5%. And the key is this has been a sustained success. We have pilot programs looking to improve hospital throughput by expanding our multidisciplinary rounds to twice a day, which is almost our internal PAC team, to improve discharge planning, and are working closely with our transitions of care pharmacy and Nari and his group to improve turnaround time for patients to get their prescribed meds on discharge and improve discharge time out of the hospital. Next slide. Next, I wanted to present some of the work being done by my colleagues in behavioral health and services department and VMC acute psychiatric services to reduce the number of non-acute psychiatric patients at VMC inpatient psychiatric facilities. I want to recognize Margaret Obelor, who I spoke with and gave me a lot of the information to what I'm going to be presenting to the board today. And I want to recognize the work Margaret and Tony Tullies has done on this particular issue. This has been collaborative work that has been done to improve the timeliness of non-acute placement of patients from the ED, EPS, and inpatient psych services. Similar to the non-acute medical team, we focused on strategies on working with community resources to ensure availability of placement and step-down options, and making sure patients with the proper acuity are matched to the same level facility. The facilities include Napa State Hospital, which takes the highest risk patients, including those with a criminal history, a history of assault, and those that cannot be treated at community clinics. However, Napa has capacity constraints. Notably, we have contracted with Institute for Mental Disease Facilities, or IMDs, and their psychiatrists to take step-down patients that don't meet the high acuity of care necessary at Napa. These contracts include extra funding and incentives and were key to us establishing those contracts. Also, we've partnered with crisis stabilization and crisis residential facilities, which are outpatient facilities. They also serve as step-down from the IMD once the acute psychiatric crisis has resolved. Next slide. We have had success with these strategies, including a 43% reduction in non-acute psychiatric patients over 3 years and a 33% reduction in total census. So the spike you see at the end of last year is a result of losing a contracted psychiatrist at one of the IMDs. This illustrates how tenuous this process is and how dependent it is on our relationships with the community resources. Next slide. So in summary, we have reduced the non-acute psychiatric patient average daily census by 43%, and we plan to continue to maintain our relationships with Napa State Hospitals, IMDs, crisis stabilization facilities, and appropriately placing patients to the proper level of care and reducing unnecessary locked facility days. Thank you.
Before we go on to the next portions, could we take a pause and talk about those two areas that I think constitute sort of a coherent conversational block of issues that it might be helpful for us to just pause and talk about a little bit, understanding that they may connect to other issues as well. So Supervisor Ellenberg, I see your light is on. Go right ahead, and then I've got some questions and comments of my own.
Thank you. I appreciate the stopping here. Love the video.
Thanks.
I think that's a great piece. I have two questions, one about the skilled nursing facilities and one about the psychiatric step-down facilities. The skilled nursing facilities, use of the contracted facilities does indeed sound like an excellent way to reduce the number of patients who are hospitalized. Does it challenge your other goal of trying to reduce outside costs? What is the cost of keeping somebody in the hospital versus putting them at a skilled nursing facility look like?
The cost is considerably less to put them in a nursing facility. I think we can, it does add to our outside healthcare costs, but the overall cost, if you were able to compare it, skilled nursing facility versus being in a hospital, is considerably less. The numbers I've heard, and these are the ones that I've heard, but I welcome somebody from the CFO's office or Paul to also confirm, is I've heard just simply being in the hospital without any treatment, just a single day, is at least $2,000 to $4,000 between those numbers, depending on which level of acuity bed you're going to be in. The current contracted beds that we have at the nursing facility, my understanding, is about $500 to $600. Is that correct, Paul?
Right. So the cost per hospital day is much higher than that, $5,000 to $6,000, depending on the level of care. The contract that we have established with the skilled nursing facilities are pretty unique. We've been able to make arrangements where we only pay if there's an empty bed. Otherwise, they bill and collect for all the other services that they're providing if we place a patient there. So it's a very unique contract, and George Harrell is here who helped negotiate these contracts. So as long as we keep the beds filled, there is no cost to the county. They bill and collect the Medi-Cal, however, with the exception of the uninsured. When there's no payer available, we do pay that rate. The rate is, George, what a day?
Excuse the interruption, folks, because I want to make sure I'm tracking the response, and I apologize. But so we contract for a specific number of beds, as I understand it, and as long as those beds are filled with folks in our contract, the skilled nursing facility is prepared to say no charge to our system because they're able to bill for services provided to people in those beds. Yes. But if we have an empty bed, meaning we haven't moved somebody into one of the beds we've contracted for, then there is a charge to our system because they're not otherwise able to charge anyone for services because they're not providing any services to the person that isn't in the bed. Is that?
Well, that is correct.
But just to clarify, in the capitated managed Medi-Cal arena population, Valley Medical Center isn't paying for those beds, but Valley Health Plan is contracting with SNFs to pay for those services. So in a fee-for-service world, so to answer your question, there is a little bit of a relationship between we reduce the success we see in the non-acute patients in the inpatient stay will lead to more patients in a skilled nursing environment, which in the capitated population does result in payments that translate to outside medical costs that are through VHP contracted services with outside SNFs. Does that make sense?
And no matter how you cut it, the fact is that this is much more effective and a much more cost-effective way to provide the care. And the other thing that's really important, and I think we know this, and Dr. Smith has said this many times, it's much safer for a patient to be in a skilled nursing facility and getting the appropriate therapy and the level of care than being in an acute care hospital.
Right. So what you were talking about is essentially just an accounting decision, whether the money comes from the VMC general funds budget or from the Valley Health Plan?
No. Valley Health Plan gets most of its revenue for these patients from the state funneled through the family health plan. So that's our managed Medi-Cal program. And so it's not money that comes out of the general fund, it's just money that comes from Valley Health Plan. Now, Valley Health Plan takes some risk because we get a capitated rate, so we have a responsibility to use that resource effectively, but we've done a great job of doing that. Now, there are a few, quote, commercial lives, meaning either covered California or employees, that where the premium comes from a different location than the state, but still Valley Health Plan is paid for those, so it's not a general fund cost. Whereas keeping people in the hospital who don't meet acuity means that no third-party payer is paying, so therefore we are paying out of the county general fund ultimately.
Thank you. I appreciate the clarification. And moving away from the SNFs to the psychiatric step-down facilities, what is the capacity of those facilities at that time? Do we have enough placements to meet the demand, or are there particular types of facilities where we need additional capacity?
Actually, all of the redesign has been developed to address these needs. So when you look at all of the new services, the levels of care, what we've done with the SNFs, what we've done with the IMDs, residential care facilities, all of that expansion is to serve this exact population and other people like it. So we can do a refresh on the information we've shared, but all of that information ties into the work that we've been doing with VMC.
Could I ask?
Thank you. I do remember. I'm sorry. I'm just
No,
finished,
I'm
but the
interrupting. I apologize.
I don't need the refresh. I really appreciate that. I'm excited about all of the new programs that are being stepped up, but I didn't realize the direct connection. I assume the numbers you chose weren't random, but I think it's 170 additional
We have about
beds?
155 IMD beds that we monitor, and what we're hoping with the new services that are going online now is that for those individuals who've been in IMDs because we haven't had a level to step down,
Right.
that working with the Public Guardian's Office, we'll be able to move people into the ACT programs, and that will open up more IMD beds, which will allow us to get all of those folks out of BAP and the other hospitals into that level of care, and we'll have a full continuum from crisis into the community.
It's an incredibly complex puzzle, but thank you. Those are all the questions I have so far.
So, Ms. Tullies, does that mean that at some point we won't need to send people to Napa because we'll have capacity here in Santa Clara County even for that level of acuity?
Unfortunately, no. We have 55 individuals at Napa right now. Our staff checks and does clinical assessments, and unfortunately, those people need to remain in Napa, and they will be there for the rest of their lives. It's unlikely that they'll ever step out of the hospital.
Okay. Following up on some of the issues, Dr. Karani, that you've already raised and that Supervisor Ellenberg has addressed, and let me go to both you and to Mr. Lorenz, if appropriate. So when we reduce the number of non-acute medical patients in our hospital system, are there people who can use those beds who are then filling those beds that we have freed up? Presumably, Dr. Carney, I sometimes tease Mr. Lorenz about when he comes with the good news that every bed in the hospital is full, and I always joke that only a hospital administrator can think that's a good number to tout, and he knows what I mean by that. But presumably, there's a benefit in terms of those beds then being put to good use for folks who otherwise wouldn't have access to those beds. I just want to check that that is in fact the case.
That is in fact the case. I think I was at VMC. I've been at VMC for over 20 years. I remember when San Jose Med shut down and the resulting almost tidal wave of patients that came to VMC, which overcrowded our ED and our hospital as well, and the general. We were overall under-bedded here in this county, so we had to figure out a way to create more efficiency within the hospital. And what we realized through our patient flow program is we couldn't just push these patients out while they're sick. we had to recognize our quote-unquote low-hanging fruit. So definitely the non-acute. Those are staying here for avoidable days, which can be on the weekends when we don't have quite the same staffing, how to properly staff so that we can reduce those avoidable days, and then avoidable admissions as well. So this is just a segment of the work that was being done by the Patient Flow Committee. So by reducing the non-acutes, what we've been able to do is improve the flow through the ED. But I think the key, and we're going to talk about this later, is it's allowed us, since we've had the acquisition, to be able to keep those higher level of care transfers that are occurring throughout the enterprise, within the enterprise. If we did not have this capacity, they would be leaking out potentially. And so I think that's one of the benefits of reducing our non-acute census. It's not just our ED. We have to be open to the entire community, from Sunnyvale all the way to Gilroy, to take care of those acute care and emergency care patients.
Got it. Then I want to be very clear. I know the answer to this question, but I just want to revisit it because I think it's important that we revisit it every time we have this conversation. We're not pushing people out who are not ready to be pushed out. You're confident about that?
I am confident about that, and I think the best metric to show we're not is to look at the readmission rate. I mean, it's not perfect, but it's a good metric to look at, and our readmission rates are below both national and state average, a regional average. I think you also have to look at the readmission rate of these very complex patients, which are going to the post-acute care team. I think if we just bought the beds and that was the end of it, right now we'd be having a discussion of why our non-acute rate has gone so far up. We needed to have that team there to make sure that they weren't getting readmitted back to the hospital, that they were re-entering the community. I think a 5% readmission rate is outstanding.
Then to follow up on the conversation that Supervisor Ellenberg began about, so by definition, this process is going to push up our outside healthcare costs to some extent. Yes.
Yes, it can.
And I understand the trade-offs. Where I'm headed with this is, and if you want to defer this until we get to outside healthcare costs. Does that suggest that we should be providing some of the services which we now contract for in outside healthcare costs? In other words, if we're going to say we're going to move folks from here to there, and that's pushing up our outside healthcare costs, are there some services in this outside healthcare cost arena that we should perhaps be looking at providing ourselves in order to avoid those costs? Or do we think that, frankly, the best practice, both financially and in terms of patient care, is to contract out for those services with these outside healthcare providers?
Let me jump in.
I thought you might.
First of all, to state the obvious, but just to make sure that everybody listening to this conversation understands it, the whole key here is to get the right level of care to the right patient at the right time, and not to have people languishing in the wrong level of care and high risks. And it's been well demonstrated that inpatient hospitals are very dangerous places if you're not in need of a hospital. Mistakes happen, people get killed by the wrong drugs. It's not a good place to be unless you really need it. So having somebody languish for a month in an inpatient bed who's not in need of that is a very dangerous thing for them. So what's being used is the state-of-the-art process of following people along the entire course of their illness, and really, rather than pushing people through the system, pulling people to a healthier part of the system. And it's just really doing a fabulous job, and the team has been committed and owns the process and is doing a really great job. Now, to try to get more specifically to your question, the costs of outside care that we were concerned about before, and still are concerned about primarily have to do with patients who go for at the beginning of their acute care episode to another hospital or another system, like going to Regional or Stanford, or those who are referred from our system to Regional or Stanford for extensive care. That's where the major costs are for the so-called outpatient costs. And those costs come because we have the responsibility for those patients and we need to pay for them. The kind of outside medical costs that we're talking about here are many orders of magnitude smaller, and actually many of those costs are paid for by third-party payers. So it's a major reduction in cost per capita. But the real issue is not so much the cost per capita, but the correct patient care. I don't want to ever give anybody the impression that what we're doing is, quote, saving money. What we're doing is augmenting access for other people who need it. We don't save money around here unless we fire people. We're not doing that. What we're doing is allowing more patients, and you saw in the graph earlier, more patients to get the care they need. In terms of the question about should we be actually providing some of the outpatient services that are being talked about, skilled nursing facilities or IMDs or psychiatric health facilities, so-called PUFs. Actually, you and the board have told us to embark upon that with the building of the new facility for inpatient psychiatric care, which will probably be licensed as a PUF and will be able to address those issues. So yes, there is some need for us to take that on. We have to be very careful about how we take it on and how we run it. It's a very difficult business to get into and do efficiently and effectively. So there will be more coming. We will be expanding more. One of the reasons for buying the two hospitals is that we do have the capacity at O'Connor specifically for a long-term care facility. They currently have long-term care patients. We can expand the capacity there to take as a step-down kind of unit. And we're thinking about coming to the board and asking in the future, don't hold me to this, for authority to build a skilled nursing facility in the, whatchamacallit, DePaul property.
Thank you. Let me, and the psychiatric facility we're talking about, Ms. Tully and Dr. Smith, is the one I think we're still scheduled to get a report on in January with some board action to move forward on plans, yes?
Right.
Thank you. And understanding that, so the skilled nursing facilities I understand and the behavioral health costs I understand, but and if you want to wait, Dr. Cryan, until we get to the rest of the report, but a couple of the places I noted significant increases in outside healthcare costs, if I read the report correctly, were in dialysis with a 33% increase, and at Stanford, where we saw a growth from 11.7 million, I believe, to 18.7 million, which is like a 60% growth in outside costs. So if you can be prepared to speak to that when you make your presentation in a few minutes on those issues, because again, the question will arise, at least for me, are we paying somebody else to do this because it makes sense to pay somebody else to do this? Fair enough, that's going to be the case. Or are those, is there a reason for those increases in particular, but also whatever those reasons might be, are those lines of service that we perhaps want to contemplate ourselves? Or does that not make sense for some good financial and or medical reason. I think that's it for me for the moment, at least on the first two items, and we can let you get back to picking up your train of thought if you can remember where you were all those minutes ago. Thank you.
Well, I was going to hand it over now to Serena and Dr. Suarez, who are going to talk about primary care and access.
Thank you.
And then we'll circle back.
Good afternoon. My name is Serena Sai. I am the Director of Operations for Primary Care.
And before you go further, let me apologize. You're a little soft, so I'm going to ask the clerk to raise the volume, please, and I'm also going to ask you to lean in on that microphone. Thanks.
Is that better?
Way better. Thanks.
Okay. So my name is Serena Sai. I'm the Director of Operations for Primary Care. When I first started in this role, I was promoted into this role in January, and I know that one of our key performance indicators was hitting the 2.5 patients per hour. And I can tell you that it was kind of a bad word at that time because it was really difficult to achieve. So what we've done since then is we spent the past several months really focusing on taking it apart and rebuilding it. And what I mean by that is we obviously need to find clinic efficiencies and work on team-based care, but how do we do that? So primary care is devised of a partnership between the nursing staff, the leadership, the physicians, and also the community. And what our target was that we wanted to create value-based service to our patients, and we wanted to improve the experience that the physicians were experiencing as well as the nursing staff within the division. So we set off by, what we did was we had a meeting of the minds. We then created a seat at the table for all of our providers and all of our clinics, and we started again. And in doing that, we looked at more things than just the 2.5 patients per hour. We looked at all the factors surrounding a patient's visit, what the throughput was, how they engage us, how they make an appointment, and how they move forward. So my role was to develop a robust cross-functional team that's going to take a look at all of that to create opportunities to find efficiencies and to improve patient flow and ultimately provide value to our patients and their experience as well as our providers. So what we did was we took a close look at our schedules, our utilization, and looking at developing best practices. And primary care is dynamic, it's changing, and we have different key metrics depending on the different programs that we are working with. So we've, keeping in mind all of those other things. So as of now, one of our goals, thank you, was to achieve patient-centered medical home. And so we've been working under this model for the last several years, but as of last week, we have just obtained our recognition from NCQA to be medical homes for all of our primary care clinics. That was, to say the least, a pretty big task because there were hundreds of measures that we had to check the box of. But what we wanted to do also was to create an expansion in primary care so that we had more interventions, a wider array of services so that we really are a patient's medical home. Some of those things we've done was we created pharmacy interventions in partnership with Nari and his team. We have referral coordinators, we have population health coordinators, we have complex care nurses that follow patients who are high utilizers of the system and work with them as their coordinator. We've also partnered with whole person care and added additional nursing staff and community workers so that we could follow a patient through the experience of their care, not just in primary care, but as they move through the system. So I am really proud of our team because this was a really big undertaking for us in a short period of time. And I'm going to turn it over to Angela to give you the details of the things that we've been working on.
Hi, my name is Angela Suarez, and I am actually just a month into this position as interim medical director of primary care, but I've been at Valley Medical Center since 1993. I did my internship and residency there, and I've been a primary care physician for the last 21 years at East Valley Clinic. I just want to emphasize what Serena said about the culture change that has occurred in primary care. Over the last year, we have been working closely with Dr. Benham Tabrizi and his CLT, and we have seen an increased level of engagement among all people who are participating in this. The slide up right now is our current project, and it is actually quite daunting. We are taking the visit from the moment the patient touches the system with the phone call in for a visit all the way through to the post-discharge. The difference between this project and previous projects that we've done is that the physicians have taken the lead and are driving the process to create the change, to get over the issues and the barriers that we as physicians and also patients have to deal with in everything from the pre-registration process to completing and then having resources for the healthy living assessment that we do, to having translation equipment in the exam rooms that work, and also in getting patients able to schedule their ultrasounds or other studies that we order. Currently, so one thing I just wanted to also say is that this level of enthusiasm is not just within the group who's participating in CLT, because that's just a portion of the people in primary care, but this is also now trickling to the clinics. And I just wanted to give a brief example of something that has occurred at East Valley Clinic over the last year. About a year ago, in looking at our no-show rate at East Valley Clinic, we were frequently up at the 20% no-show rate level. And myself, who's participated in CLT, our assistant nurse manager and our health center manager went back to the clinic and we said, you know, we've got to make a change. We can't improve our visit per hour rate if our no-show rate is so high. And so we sat down with our team at the clinic, which included the other physicians, the nurses, the LVNs, and also the HSRs, and said that we need to form little teams within our big team. And so what we did was we made sure that each physician was assigned to one MA or LVN and one HSR. And then that team owned the schedule for that physician, and they were responsible for making the pre-visit calls to remind patients of their appointments. The HSR would do that a few days ahead of time. The MA or LVN would do it even on the day of the visit. I can say from personal experience that my LVN would call the patient at 3 o'clock if the patient's appointment was at 3 o'clock and they weren't there, and the patient's on the other phone saying, well, I'm on the bus on my way, and she would say, well, just come, we'll still see you. Dr. Suarez will still see you. So in doing this, when really taking ownership of the schedule, we were able to bring our no-show rate down from the average of probably 20% down to and below 10% this year. And we've been able to sustain that. We started in January, and now here we are in November. And if I could show a slide with our no-show rate, you would see that it's well under the 12%, which is the goal for the organization. In addition, we've also in our clinic teams have shown better prime quality metrics. As people have mentioned before, our whole person care, complex nurse and community workers are helping our high utilization patients, resulting in lower ED visits and rehospitalizations. We also now have embedded behavioral health specialists in each of our clinic who are able to take warm handoffs for patients who we're seeing and are having symptoms of depression, anxiety, or even just stress. And we're also screening for social determinants of health and providing resources to patients who need help with housing, domestic violence, alcohol, and of course, depression. Next slide, please. So while we continue to work towards our goal of 2.5 visits per hour, we're also developing pilots to increase provider coverage during gaps. We're looking to make sure that all of the exam rooms are being used even when physicians are out on vacation or on leaves. We're also working towards increasing our evening hour capacity. So we're midway through FY20, but FY19 saw an increase in completed visits of 9,412 compared to FY18. Next slide. In addition, our visits per hour, while they're still not at 2.5, have increased from 2.01 in 2016 to 2.28 in FY19. And as somebody who looks at the visits on a weekly basis, I think that this half of the current fiscal year, we've also had an increase from that number. Each of our clinics is a little bit different, and some clinics have achieved the 2.5. Well, one clinic has achieved the 2.5, another clinic is close to it, but all the clinics are improving compared to last fiscal year. And I think, again, with the CLT projects that we have going on, with the increase in sorry, in our increase in enthusiasm that we have in the clinic. Hopefully that when we report again, our number will be even higher. Thank you. Questions?
Dr. Smith, do you want to weigh in before we get to?
Yeah, I just want to put
Yeah,
in
it's
my
like
2
cost-
cents. Having been a primary care doctor myself, I can tell the committee and the public it's a very, very difficult, challenging job. Lots of processes, lots of concerns while you're trying to really be there with the patient and deal with their medical problems and psychosocial problems. It takes a huge amount of work. And when I got here 10 years ago, just like lots of clinics and particularly public clinics, the primary care doctors here were really feeling put upon and pushed out and unsupported. And I think this team has done a fabulous job of actually demonstrating to the entire medical establishment that with ownership comes success, and people are really excited about what's going on. And they're doing a fabulous, fabulous job of actually improving patient care and improving the quality of the job and satisfaction with the job of not only the physicians but also the other staff. And it's critical to have the physicians providing that leadership. And I couldn't be more proud or happy with the transformation that you've accomplished. It's just phenomenal.
Supervisor Ellenberg.
I have no questions at this stage. I do want to add my gratitude and sense of really being impressed that you took a narrowly defined, specific, and pretty unsexy goal and managed to create this entirely new system that sounds like it will be a model for our hospital systems and maybe even broader than that at large. So thank you and congratulations on really great work. Thank you.
But before we step away from 2.5 per hour, so let me just ask, should we step away from 2.5? Is that, I mean, Ms. Tsai, you sort of said, forgive me, but what I heard was, well, we were talking about 2.5, but now we're talking about all this other cool stuff over here. And I was delighted to hear about all that other cool stuff over there. But I was left sort of wondering, so whatever happened to 2.5? Are we going to say, you know what, it's not a useful or relevant number and chuck it? Are we going to say, no, it's a useful and relevant number, but if you focus too much on the number, then you don't go deal with all that really cool stuff over here, and one day we hope to come back to you and be at 2.5? What's your take on that? For those of us who are still hung up on 2.5, so.
Well, we continue to work towards 2.5. It's hard to see 2.5 patients, which is 10 patients per half clinic. We currently have 11 slots on our schedule, but even with the bringing down the no-show rate, that could still be one patient who doesn't show up. That could be a patient could cancel. That doesn't add into the no-show rate. And so we're still striving towards it. I think, though, that maybe a better goal would be towards visits completed. And just my thinking is that previously I was doing 7 half clinics per week, and I was hitting almost 2.5. But now I'm doing 3 half clinics per week. I'm still hitting almost 2.5. So have gone from 70 possible appointments per week to 30 completed appointments per week. And so I think that's why we're looking at this, filling in the gaps when people are not in clinic to be able to increase our visit numbers as opposed to our visits per hour. But we continue to strive towards that.
Dr. Smith, what's your thought about the future of 2.5?
It's an aspirational goal, I think, that is important to have. The Reality, however, is that there will be changes from time to time, and we will actually get above 2.5 when we have more support for the system and the processes. I think the team has begun the quality, consistent quality improvement processes that will allow us to be more and more and more efficient. But, there's lots of other stuff that we're going to need to provide support for, like simple visits over the phone or over Skype, simple refills, more training and education done by others than the physicians and nurses, staff, easier IT systems to use, more group visits, lots of other things that will be on the horizon that we'll be talking about later.
Okay. Thanks.
May I share something?
Please.
So from the hospital side, we have extreme gratitude towards primary care. You had talked about not pushing these patients out. A metric that I want to bring up was previously only 5% of our patients when they were discharged had a follow-up appointment in their hand within 2 weeks. That number is over 60%. I think that's a testament to the work that those folks in primary care are doing right now to make sure there's access for those patients.
Great. Thank you very much. Thank you both. And next part of the presentation is
outside healthcare costs. Hi, I am George Harrell. I'm the Director of Business Development and Managed Care for the hospital system for Santa Clara Valley Medical Center. And we touched on this already a little bit, but I just want to recap that the cost paid to outside providers to deliver care for the managed Medi-Cal population, the VHP managed Medi-Cal population that's been delegated to us so that we have full cost risk to manage this patient's care, really breaks down into two categories. One is contracts for services to providers, outside providers, to provide services that VMC does not currently provide. We touched on a little bit of that: durable medical equipment, skilled nursing facilities, specialized higher level of care. For example, Stanford for a transplant, we don't do transplants, or specialized neurosurgical procedures that we don't do. The other category is the outside cost for that we contract for to supplement our services. And this is really to provide expanded member choice and additional capacity to the system. So these are categories of services that we do provide. And this looks at things such as outside hospitals that we're contracted with, Regional Medical Center, the other hospitals in the area. Up until last year, O'Connor and St. Louis were contracted as outside, and we've now brought them in. It also, to the discussion earlier, we provide dialysis services, but we have capacity constraints, so we do also contract out to outside contracted dialysis.
So let me just stay with that for a minute, if I may, and forgive the interruption again. So if I noticed, I think it was a 33% increase in dialysis outside costs. Is that simply because we needed to provide more dialysis services to patients in our system, and we were already at our peak and or our limit, and we said, all right, then that means we go to our outside provider?
Yes, we probably service about a third of the population, and that continues to grow. There's some other nuances there that we're continuing to explore as to how we might be able to better control that growth, but that's what that's reflecting.
And then if I couldn't help but notice the significant increase in expenditures at Stanford, as I mentioned earlier. So, I think it's a 60%, if I did the rough math in my head pretty quickly, growth. To what is that attributable, if I may ask?
Yeah, and so we're jumping a little bit ahead, but certainly for the sake of time, last time we were here, we were talking about that there was a market adjustment new contract with Stanford. I think you saw a partial period impact last year, which was showing that there was still an increase.
Excuse me, I just want to make sure I understood the jargon correctly. Does that mean they raised the prices?
Yes, that meant they raised the prices.
Okay,
that meant that we enjoyed probably very much below market prices for quite a long time. And there was a market adjustment to try and bring that more in line with current rates. And it was significant, and we're feeling the effects of that. And last year, you saw a partial year's impact. This year, you're seeing that continue through a full year's impact. We can show how even with that upward trend at Stanford, some of the utilization management that we've done as stewards to try and control the costs that we can control, that we've been able to at least mitigate some of that growth. When you look at just Stanford, you see a pretty significant growth. When you look at hospital admissions, which we can jump a couple slides ahead. This is the breakdown, and you saw, as we talked about on the skilled nursing facility, there really is a big cost differential between inpatient as well as all the other clinical things that were positive. But you do see an increase in the skilled nursing facilities. And if we go even to the next slide, and we all recognize, I think just the slide before, we all recognize that the benefits of us focusing on improving efficiency, increasing capacity, keeping more of the capitation dollars within the system instead of paying it out to outside providers, providing better quality and continuity of care. Those are all very positive things for us as a system. And so that's really been where we've been focusing. And so our strategies have focused on three major initiatives, three levers that we feel best control this. Coordinating the inter-system transfers. Now that we have 3 hospitals, really working better to control within the 3 hospitals to keep more patients within the system. Also working together with our partners at Valley Health Plan to better control repatriations and bring more patients back into the system. So to your point about do we want to contract with outside providers? In the case of the hospitals, you know, we've got a situation where we provide opportunities for member choice, but we also, through being very proactive and reaching out to those hospitals, being able to bring more of those patients back in that present at outside EDs back into our system. So the third area is focusing on reducing unnecessary referrals to outside specialists. When we refer to an outside specialist, this is primarily Stanford, inevitably that then leads to an inpatient stay, which is a high cost area of the outside medical costs. And it also oftentimes leads to us losing the patient. They're lost to follow up at Stanford. They stay at Stanford. So really working to increase engagement and awareness as well as expanding capacity. Next slide. So when we look at, this is what I just touched on, you know, you can see that over the last 3 years, we've had really a significant improvement in claims reductions, which also translates into utilization. We're seeing less utilization of outside services, but we are seeing a flattening, but we haven't seen that same decrease, and that's primarily due to contractual rate adjustments. Next slide. A real positive of the integration of O'Connor and St. Louis. Just since March 2019, for the 4-month period till the end of the fiscal year, we saw a proportionate decrease in claims and dollars, and we fully expect to realize all those savings at the end of this fiscal year, this fiscal year, as integration will now cover the entire fiscal year, as well as we will see much lower, if none, pre-acquisition claims from before we acquired the 2 facilities. Next slide. Talking about not just integrating those 2 facilities into the system, but also some of the discussions that you've heard about really working better together and smarter together. We've really improved the coordination through the transfer center. You've heard about the transfer center in the past. The transfer center is really functioning in a very key coordinating function now with 3 hospitals. And if you look at the period, the 5-month period from May to September in 2019, we've retained 90% of the patients within the system and only transferred out 10%. When you look at that same period a year ago, transfers between St. Louis, O'Connor, and VMC when we weren't integrated was 33%. So 33% was only 66%. 33% of patients that presented at St. Louis or at O'Connor were being sent to outside hospitals, regional, Good Sam, other facilities. And I think just a second for we can stay here, but Dr. Karani just can speak to some of the work that the transfer center and the integration team has done.
Yeah, I mean, on the first day of the acquisition, the task we were given was to make sure that all the acute care and emergency care between the three hospitals were integrated, and understanding that there's different capacities between St. Louis, O'Connor, and Valley Medical Centers. There's different specialties available at all three as well. So we created this nerve center, which you know is the enterprise transfer center that tries to match these patients, their acuity, the services they need, and the bed capacities on the back end to the right place, understanding that many of these diseases are time sensitive. For example, somebody coming in with a STEMI or a ST elevation myocardial infarction, or a fancy way to say heart attack over at St. Louis, and then has to, within 90 minutes, get an angioplasty. How do we do all of that when it's 5 p.m., or I should say 8 a.m., and there's a lot of traffic coming from St. Louis? So all of these things have to be done in a time-sensitive manner, and if we don't have the capacity, then these patients may have to leave the system. There's concerns about quality of care then that could come up. And I think that goes all the way back to all the discussions we had about why non-acutes are so important. By reducing that non-acute level, that number, we're able to have the capacity to be able to keep these patients within our system and make sure quality of care is maintained within the county.
Thank you.
So during that 5-month period, we've added, basically 120 patients, additional patients stayed within our system that a year ago were going to outside hospitals. And that translates into a significant savings. Next slide. We also talked, one of our other initiatives is really working in a more integrated fashion with Valley Health Plan. And I think when we met last, we had talked about that we were just beginning a pilot to really try and get the transfer center and the UM teams at Valley Health Plan and the transfer center at VMC to work better together. And you can see that we've continued to evolve and improve utilization at outside hospitals. I'm using the HCA system because that's one of our biggest facilities between regional and Good Sam, where we see patients presenting at the ED and wanting to bring those back. And you see that we've had some significant improvements there. And that's really through improved integration, and we continue to do that. We're continuing to work with our partners at Valley Health Plan. Next slide. This is specifically focusing on Stanford, and I think we've initiated some strong programs both to reduce specialty referrals for higher level of care to Stanford if we can handle those services inside, because as we mentioned, if you send a patient out for a specialty referral, it inevitably will lead to an inpatient stay. So you can see that we've had some significant reduction in hospital claims. However, as I mentioned, because of the impact of market rate adjustments, we're still continuing to see, I believe we're at the apex and that it's going to start to flatten out, but we continue to see through fiscal year 19 that it's continued to climb on a dollar basis, even though claims have decreased. Next slide. So summarizing, we're going to continue to focus on intra-system collaboration and communication through the transfer center to ensure that we maximize the number of patients that stay within the system. We're also going to further integrate our work between the transfer center and the VHP utilization management teams to ensure that we continue to increase repatriations from outside EDs. And then we're also focusing on reducing referrals out to specialty care. For example, we've really made a big impact on the oncology teams in terms of referring out to Stanford, whereas a couple of years ago, a significant chunk were going out. We've probably reduced those outside referrals by 40%. So we're now focusing on maintaining those patients within the system when we can. But we're also looking specialty by specialty to look at where can we improve capacity and increase capacity to ensure that patients stay within the system. That's it. If you have questions, I'm happy to entertain.
a really comprehensive and detailed report. I appreciate that. The report briefly mentioned the 3 new operational imperatives that will be analyzed for future reports. Can you just let me know how those 3 were selected?
Well, particularly with the acquisition of the 2 additional hospitals and the close proximity of O'Connor and VMC, we really want to take advantage of how do we better integrate that increased perioperative OR capacity, and how do we work better together to be able to grow surgical procedures within the system. That was one of the key areas there. And the OR is such an important part of driving patient care within the system.
So is this a group decision, a large stakeholder decision, a small number of people? I'm just curious about the process.
Well, we had the luxury with phase 2 of not having it necessarily become an imperative that was given to us. We got to look at it and identify areas that we proactively thought would be a positive for the system. And so it was an internal choice as opposed to...
That was a very good euphemism.
But it also goes to Dr. Suarez's earlier point too, that when you have ownership, there's excitement and energy around the work.
Yeah. And even in specialty, you know, I think you heard a lot about the collaboration and the fact that we're talking more amongst groups. And I think looking at specialty capacity expansion is also really engaging primary care to help work together on some of those. So we are seeing improvements there as well.
And Supervisor, if I may, so what was interesting about these 3 operational imperatives, they were actually selected and started prior to the acquisition, obviously, in terms of engaging in it. It just so coincidentally occurred that while we're working on these initiatives, the realization in working with Dr. Manesh Bhimani and Pat that these were perfect opportunities to align the systems and actually to, you know, further the team effort relative to a 3-hospital system. I think over the course of the next year, you will be able to see the benefits of a 3-hospital system in these 3 areas. And
thank you, and congratulations to you too. This is really a tremendous lift. With that, I will receive the report if there aren't any other comments. And moving to item 8, let me see if we have any speaker cards. On item, we're going to hear all of the 8s together. So I have, only one nonetheless. Scott Largent on 8D, but we're going to hear all of 8 together. So come on up. Thank you.
Oh, do you want me to come up and do the, okay. Just making sure. Sorry about that. Good afternoon, everybody. Almost evening. I always come up for the behavioral health item. I've been really starting to film everywhere I go now. I've been, it's not that I'm obsessed with this. It's just that first you'd hear the screams and you kind of would go in the direction of that, and then you'd start filming. And then you follow the sirens, and it was about 2 or 3 videos a day downtown. Now it's 30 or 40. I go to different meetings that nobody here really knows about. They're kind of these rogue ones off to the side with different activists that are frustrated with the system, but they want more things to happen. And the feedback I'm getting from some of the other people off the streets right now is that they need more protection from the mentally ill in these homeless encampments, you know, down at St. James Park, on the railroad tracks. The police department is not vetting these people out. They're leaving the bad apples there, the ones that are running around with machetes, the ones that are, you know, smoking meth in public, yelling, fighting, and nobody's pulling those out of a situation. I started getting more videos now where just random people start running up and screaming and yelling and picking fights, and And these are the people that are taking advantage of the mentally ill and the homeless that are in the situation that they're in downtown. I just wonder why the police, why they don't do more. Why are they not protecting these people? A couple bad apples out of one encampment can kind of wreck the process for these people that need help. And I would really like for the police department to get out there. And maybe, just maybe, at these light rail junctions downtown, maybe we could start staffing them. Maybe put a couple sheriff's deputies at each one of those light rail stops. When I leave my court appointments, I'd like to go down there and be safe at that light rail so I can get home. I don't want to smell the methamphetamines. I don't want to watch people smoking dope. And who put drug court right across from St. James Park? Should be right here at the Hall of Justice. Thank you.
All right, thank you. That takes us to items 8A through F, and we will begin with the report from the director.
Yes, and good afternoon, Mr. Chairman and Supervisor. In the interest of time, we had prepared a presentation on whole person care, but I think it's such a wonderful story because it is a multi-layer, multi-dimensional initiative for us. As you could see, you heard it from prior presentations, it's linked to our Transformation 2020 efforts, as well as scaling up what we already know. It's evidence-based in terms of what we need to do with the high utilizers. Michelle Delacaya is here, who's the new director for the Office of System Integration. But what we'll do is we'll hold off unless you have any other questions until we can dwell maybe at a later date or meeting into a little bit more details in terms of what this project means for all of us.
Thank you. Supervisor Ellenberg, I just, full disclosure, I reached out to the director and said, I don't want to rush this, and I also want to make sure, I mean, this is a big deal. I'll just let it go at that. And it's also a big deal in connection with some of the other conversations we're going to have around related topics. So it seemed to me that rather than rush it and have it in isolation, it made sense to hold off, have the conversation as part of a longer conversation and integrate this topic with others that are related. So I don't want to preclude any questions you might have today, or if there are things you'd like to say, hey, can we make sure we don't forget to talk about this, that, or the other, this would be a good time. But that's the reason for the director leaning in. So I appreciate him accommodating that approach.
And I am absolutely amenable to holding off on the whole person care report and discussion. 8A also includes EMS report. Do you want to hold that?
No.
Well?
I have some questions about EMS. So, but if you have questions about EMS, go right ahead.
All right. Terrific. And is Jackie here? There she is.
Yes, we have Jackie Lowther here, who is the EMS director, as well as she has some guests for you in case you have any questions.
Great. Thank you and welcome. With regard to the missed compliance by county ambulance in August and September, can you share a little bit about what accounts for the decrease in compliance below the 90% threshold? I see that we missed one zone in August and 3 in September.
It can a little bit, and as Mr. Santiago says, I do have some guests here from Rural Metro AMR that can probably help fill a little bit on their part. If Sharon Henry, you moved over here, if she'd like to join me.
Please.
So the EMS agency receives data on a monthly basis from Rural Metro AMR, and we have met. Sharon, do you want to come over here and sit next to me? So we met yesterday, as a matter of fact, and to discuss some technical difficulties that they state they have been having on the collection and, for us, the validation of this data. We have not been validating that data ourselves. We don't do it. We get it from them. And so currently we're working with County Council and Rural Metro on rectifying these issues so that we can do and present what they say is the correct data from their point of view. So I'm going to let Sharon speak to you for a moment, and then she can pass it back over to me.
Okay, let me just make sure that I'm clear on even where we're starting. There's different data from AMR and from EMS? Are you not just getting the data from them and reporting it?
We get them directly from them, and that's what we report.
Okay, then it must be the same data.
Go ahead, Sharon. No, you just turned it off.
I don't know what I'm doing.
So introduce yourself.
Hi, so I'm Sharon Henry, the
Sharon.
Chief Operating Officer for AMR's West Region. So everything in EMS ends up more confusing than it should be, and more confusing than it probably needs to be. But the compliance that we're talking about today that's causing the erroneous numbers is not about ambulance response times to patients. It's about the instances when an ambulance is canceled in the middle of a call before it reaches the scene. And we're having some confusion and difficulty with the computer system in the way to measure those canceled calls. So the way it worked in the past was if an ambulance was canceled, if it was already beyond the response time, it was considered late, as it should be. If it was canceled before the response time requirement, it didn't count as good or bad and was thrown out. That was in the legacy agreement. We all worked to try to improve that, which probably, looking back now in hindsight, made this more difficult by counting calls when the ambulance is canceled. If it's late, like it was. If it's on time, though, the question was, how do we count that? How do we know if the ambulance would have been on time or if the ambulance would have been late? So we all agreed to use a predictive model because we use in the dispatch center a very sophisticated model. At the point of dispatch, it tells the dispatcher the dispatch time will be anticipated to be 8 minutes and 32 seconds. So when the ambulance is canceled, we're using what the predicted dispatch time was. So if they're canceled at 2 minutes, but it's predicted at 12, we would count it late. If it was canceled at 2 minutes, it was predicted to be 4 minutes, we would count it on time. And that's what we're endeavoring to do in this new agreement. The problem is the computer system is picking up the wrong data elements, so the data that's coming out is incorrect on all of the canceled calls. It's reporting them being excessively long when they're not. So there's some data element pickup issues. Those numbers come straight out of the CAD. I can't manipulate them even though they're incorrect. That's why it looks like I'm giving her data that I disagree with.
And what are we doing to remedy that so that we are better able to track when we need to charge late fees?
That's exactly right. So we met yesterday. We're meeting again with the EMS agency. We've made several calls to the computer manufacturer, and I think we're narrowing in on a solution that I believe we'll have done in the next 30 days.
What we met yesterday about supervisors and are discussing with county council is if there's a mechanism temporarily that we can use our previous mechanism of looking at response times, and we've discussed it with Wesley Dodd. I've included Doug, and if you want to jump in here.
Yeah, I would say we probably don't want to get into the detail. I think we're trying to stay within the language of the contract that was negotiated, and I think that's sort of our framework that we're working with.
We're all interested in that. I think we're getting closer to that, but we're compliant. When we go through and manually do what we said we were going to do in the amendment, we're compliant. It's just the computer's picking up these calls, making them late, which is skewing the overall into under 90%.
Well, the challenge, respectfully, is that it's self-reported compliance. And is there a mechanism for us to validate, as you mentioned, Jackie, that our information is not validated?
Right.
So how do we do that?
We would have to manually go through what we use as First Watch to do that, and it would entail a great number of hours to do that. So we can't validate those numbers at this point.
If I could step in here.
Excuse me, I'm going to
They're not self-report.
Excuse me, I'm going to interrupt.
Self-reported.
Ms. Ellenberg, would you mind if I jumped in at this point?
Jump.
And please feel free to jump back in since I'm
I will do that.
jumping into your question. But I'm getting increasingly frustrated, so I just want to tell you that up front, and let me sort of go back to the beginning. Tell me your name again, please.
Sharon Henry.
Ms. Henry, thank you. Ms. Henry, have you appeared before the committee before? I apologize, I just can't remember.
I haven't.
I was going to say, I didn't think so. So let me just share some history with you and then try and cut to the chase here on this. Poor choice of words, but you understand what I mean. The issue of response times was an issue that I raised as the vice chair of this committee, the second member of this committee, gosh, 5 years ago, maybe 6 now. And it had to do primarily with the response times of the San Jose Fire Department as a first responder. And as you may know, they were not only struggling, they were just not hitting their numbers. And that caused me concern, and I pushed the issue. That just where it was. What was interesting is that our provider, your company in its prior incarnation, was actually doing pretty well. That while there were, I think, 1 or 2 occasions over a period of some time in 1 or 2 zones where there were missed target times in terms of the 90% compliance, for the most part, doing pretty well. When it was time to look at this new contract, I expressed my concern on 2 or 3 occasions about the fact that the penalties for noncompliance were changed from the prior contract, and in my view, provided less incentive for on-time performance by your company. So I'm just trying to tell you how I saw it and how I continue to see it. So the question that I was going to ask, but Ms. Ellenberg asked largely the same question, is I'm looking at a memo from Ms. Lowther that is dated November 13th, 2019. It is my packet page 131 for the record. What it says is, rural metro missed meeting their response time standards in zone 1, 2, and 3 for code 3 patients, semicolon. They were compliant in zones 4 and 5. Now, that's a definitive statement. It may be an error, and if so, we should just get that cleared up. But it says rural metro missed meeting their response time standards in zone 1, 2, and 3 for code 3 patients. Ms. Lowther, my recollection is that zone 1 is the North County area that I represent, yes?
Yes.
And that zone, is it 2 or 3, is the West Valley area, a portion of which I represent, a portion of which Ms. Ellenberg represents. Which one of those is it? Do you happen to remember? Is it zone 2, zone 3, or both of them?
Both of them.
Both of them, okay.
Sort of
So,
upside down.
Ms. Henry, again, rarely can I speak for my colleagues, but in this case, I can assure you would be concerned regardless of whether these were our constituents or not, but particularly if they're our constituents. If somebody's arriving late, then that's a source of concern. So the question is, was there a late arrival, or is it a misstatement to say that folks showed up late because there's a computer glitch? That's the first question. And that's a pretty basic question. Somebody called, somebody was supposed to show up. Did they get there on time? Did you meet the 90% number? So, yes or no is the question I'm trying to get an answer to here. And I'm sorry to be so, but it's like, come on, let's figure this out.
I'm a pretty direct person.
Good.
So we made compliance. We arrived on time. There is a computer glitch on these canceled en route calls. We are compliant. We have been compliant. In fact, we've added ambulances into the system. We've added more ambulance hours into the system. We've added new ambulances. We've added new equipment. Things are working. What's not working is the computer programming of this nuance in this new amendment that's skewing the data inappropriately. Another thing to Supervisor Ellenberg.
Too much information, because I'm trying to get some yes or no answers here. So are you telling me that the only time anybody was late was when a call was in fact canceled?
Oh, no.
Excuse me, that the only time that the non-compliance that is reported is a function of canceled calls?
Yes.
Okay. Or is it that there's a problem in your computer system that's misreporting the information? This is the question
The
that...
computer is misreporting the data on canceled calls.
All right. So if I was looking at all of the calls in these zones that weren't canceled, still with me?
Yes.
All calls that are not canceled, did you get to all of those 90% plus of the time? Because that's what the contract says is supposed to happen.
Yes.
Ms. Lowther, do you agree with that?
I can't validate that with the current system that we're using because I can only use what they send me.
Okay, I get that. If what she's telling you is the truth, is that a correct interpretation of what she's telling you?
Yes, and what we just can't validate it because the system that they're sending me shows them as being exactly what I'm giving you.
Got it.
And
3 years ago, did we have any ability to independently validate this information?
yes,
Did that get lost in the new contract?
got lost in the new contract because of the canceled calls. Yes.
Well,
No, not exact.
okay, Ms. Henry, here's how we're going to solve this today. And Ms. Ellenberg, I'm going to look to you if you want to chime in again. We're not going to get this sorted out in the next 5 minutes, 15 minutes, or hour and 5 minutes. So we're going to bring this back to the next committee hearing. And I'm going to tell you both, and if you can hear some frustration in my voice, it's because it's there. I'm going to tell you both. We're going to bring this back every meeting until this issue gets A, sorted out, and B, till we're sure that there is 90% on-time performance for non-canceled calls, come hell or high water.
I completely agree. May I part with one comment?
I'm going to
Supervisor
first
Ellenberg?
go to Ms. Ellenberg, and then I'm going to let you have the last word, and it's going to be a brief last word, please, Ms. Henry. Ms. Ellenberg.
Actually, my remaining comment is just to Jackie about the EMS 2022 planning. That given the short time frame since the last HHC meeting, I know that there's no update right now, but I just want to encourage that since this group is in the early stages of discussion, that behavioral health be included in the work group, and that an external consultant be brought in to help with facilitation and data analysis and review of the EMS system models to keep the work moving forward with a broad look at all of our EMS systems. So I'm moving off of rural metro.
Okay.
Ms. Henry?
Two things. First of all, the EMS agency's done a great job in helping implement the new amendment to the contract. We appreciate that.
Wonderful.
It's a computer issue. What I want to clarify is that our compliance is not self-reported. It's coming out of a validated computer system that we don't modify, we can't change, we hand it over to them. So it's not I make up my compliance, just trust me, the numbers are right. That's not how it works.
Thank you for clarifying. I
Okay.
appreciate that.
I'll see you again.
I'll see you next month.
Thank you. Back to the director.
Yes, all right, next item, it's an update from Public Health.
Good afternoon.
Did you want to talk about EMS, Dr. Cody, or
No.
Not really? Just kidding. No, I'm just giving you a little kidding there. Sorry about that.
That was too scary.
Sorry.
It's past
Go ahead.
Halloween. My only update is just to give you an update on the vaping illnesses in our county, because relative to the recent board actions, I thought you would be interested.
Thank you for that.
We have one confirmed case, 2 probable cases. So that's one additional probable case since the last time I reported. And I have nothing else to report, but happy to answer questions.
On that very issue, I'm sure you've read the same press reports in the popular press about the culprit being identified. What should we take from those reports if you have a professional observation you'd like to share with us?
I haven't read them in depth enough, apart from vitamin E acetate, but I don't know whether that's been mixed up with THC and other items, other formulations. So happy to get more information and bring that back.
Thanks. And I think the question that I was trying to lead you on, and that you're not about to be led on, but we can try it again next month, is does that mean there is a small specific problem that should be fixed, or do we stand by our view here in the county that a across-the-board prohibition on the sale of e-cigarettes is a wise course.
Well, remember that the reasons for the ban wasn't just about the vaping-related illnesses. It was largely about the epidemic of nicotine addiction in youth. So we would stay the course.
Thank you very much. That's what I was trying to make sure that people didn't all come waving their newspapers at us and telling us, see, if you just fix this one thing, all is well in the world. Supervisor Ellenberg, thank you.
Thank you. I want to make a quick comment about the PG&E power shutdowns, and thank you, Dr. Cody, and Jackie and Dr. Miller for the work of all of your staffs to respond to the PG&E power shutdowns last month, and the work to mitigate the impact on vulnerable residents that rely on medical equipment. The question I was going to ask, and for the just because it's so late, I'm putting it out there because I'm interested, but we don't have to address it right now. But I'm interested to know how the welfare checks were conducted for the residents that were identified by public health and EMS, and whether there was a feedback loop to assure that welfare checks were conducted by the appropriate jurisdiction. And given your experience with this over the last month, are there lessons learned going forward of things that we need to be putting in place, or were you happy with everything? And maybe I'll ask for all of that in an off-agenda
Sure. Just very briefly, many lessons learned.
Okay.
We're doing a full review with the Office of Emergency Management on November 22nd.
Oh, great.
There are many issues with the data quality that we got to try to understand who were the people that were most at risk and what was the equipment that they had. These data and this level of detail is important because otherwise you can't stratify and understand to whom do you need to reach out with and with what. And that data was incomplete and late.
So maybe after that report to OEM, if that's something that you can send to us as well, we'd like to see that.
Of course.
Okay, great. Thank you.
Thank you. I think that takes us on to 8C.
President Simitian, at this time I have nothing further to report. I did want to announce, and Dr. Manesh Bhimani was appointed as our hospital executive for O'Connor Hospital. I'm very pleased to announce that as well to the group.
Thank you. Supervisor Ellenberg, anything else?
Yeah, I do need to make a comment
Please.
here, because last night I had the opportunity to hear from a number of employees at, where was I? At O'Connor Hospital, and just wanted to share a little bit of that. But going back first, that as with last month's positive patient experience data at the hospitals, the KPIs are showing clearly how busy the staff are, with performance above baseline for the metrics at both O'Connor and St. Louis. And this clearly demonstrates to me the great performance of staff across the system, but also requires that we be really responsive and expedient in managing the staff integration so that the employees can continue to do this great work. I heard a lot of, and Paul, thank you very much for sitting in and hearing that as well, a lot of, I think, well-warranted stress on the part of employees who truly don't feel secure in their future here. The issues that they raised were around testing and what the next steps will be around the misclassifications and around communication in general. And I do look forward, Dr. Smith, to getting the communication plan off agenda that was requested at the October HHC meeting. I think that's really critical, and not only a communication plan for what's going to happen between now and the end of February, but we also really need, I believe, an 18-month plan. We don't want to find ourselves, I don't want to find myself, in the same position when we're close to that 18-month deadline with failed tests and a short timeline. And I think as we enter that next, or get close to that next phase, it is really important to have a plan that employees can look at, can rely on, can understand what is lying ahead for them. And given all of the work that you're all doing with the hospital integration, that ESA is doing with the employees, if we need somebody additional on a temporary basis to really focus on the employee issues and make this very customer service facing with the employees as our customers, I think that's really critical to the mindset, to the workplace environment, to the support that we should be giving to our employees who are clearly working really hard and getting great results.
Will do.
Thank you very much. The sooner, the better, please.
Thank you very much. That takes us to 8D. Ms. Tully's, I believe this is your,
I have nothing to add.
all right,
I'll be bringing information in December and January.
okay. Anything there, Ms. Ellenberg? Nothing?
Nothing either.
All right.
Thank you.
All right, how about 8E? Valley Health Plan?
Thank you. I also have nothing to add, but I'm available for questions.
Okay. And anything from Ms. Ellenberg?
No,
on
I'll
8E?
look forward
Okay.
to next month's annual
All right.
report.
8F, and that, I think, means we go to you, Mr. Margolin.
Yes.
Thank you.
This is the federal update, and while impeachment is the dominant event in D.C. certainly today and will be for the next several weeks, there are a few health issues worth highlighting. The first involves the federal budget process. Efforts to get a continuing resolution that would push the budget issue until next year have failed, and Republican and Democratic leaders in the House and Senate, as of yesterday, acceded to the president's request that the next continuing resolution only last until December 20th, which sets up this Christmas Eve budget crisis scenario, which everyone but the White House wanted to avoid, but that's the reality that we're now dealing with. On the drug pricing issue, which we've talked about on multiple occasions, Speaker Pelosi is still moving ahead, but because she's waiting for a Congressional Budget Office full analysis, she just announced a couple days ago that she won't bring the bill forward for a vote on the House floor until December. So that's delayed for a few weeks. There are a number of initiatives, two initiatives in particular, that CMS, the Centers for Medicare and Medicaid Services, are pursuing on the regulatory side that we should note, one of which is important in terms of policy direction, but will not really impact California very much. And the other issue I want to highlight could impact California in a very significant way. So the first issue involves an announcement by Seema Verma, the director of Medicaid Services, CMS, yesterday, that she will soon be issuing guidance that will allow states to pursue per capita caps or block grants on a voluntary basis through waivers on a statewide basis. This is the same policy that California and other states opposed when it would have been mandatory as part of ACA repeal. The new CMS strategy is to make this discretionary and to allow states that want to cap their Medicaid program to, on an experimental basis, go ahead with that policy. And the focus here is really the rationale that they're going to use will be that they want to preserve dollars for the core Medicaid population of children and the disabled, and not spend as much money on the new expansion Medicaid population of childless adults. That will be the rationale for capping the program, but we'll see how that plays out. The policy is currently under OMB review. Again, it won't impact California because a state has to choose this course, and our state will not pursue this option. The other regulatory action, which was released in draft form yesterday, is a major concern for California. It is a proposed rule called the Medicaid Fiscal Accountability Rule, MFAR, another acronym we'll all have to learn to use. The rule focuses on supplemental payments under Medicaid. These are payments above the base payments. Base payments are for services. Supplemental payments are additional add-on payments that are designed to encourage various types of initiatives, primarily quality initiatives. They're an important part of the Medicaid program. CMS's goal with this rule is to clamp down on these payments, which have roughly doubled since 2010. They think, CMS thinks, the payments are overused and that there are abuses here, misuse of federal dollars. So what's the California impact of this new rule, which is complex, 200 pages long?
Before you go down that path, could you just remind us, or at least remind me, the payments we're talking about are from whom to whom for what?
they would be payments involving the use of federal matching dollars, which is why the feds are concerned, for that would go to providers, ultimately, our provider delivery systems, for services that are designed to improve quality of care, or in the case of a rural jurisdiction, might be designed to keep a provider system that would otherwise not be able to functioning. There's a whole range of purposes, but it's not what it isn't. What the base payment is you provide a medical service, and there's a Medicaid code specific reimbursement for that. The supplemental payments are add-on payments that provider systems typically get for these other kinds of initiatives that are designed to improve quality, access, make the system stronger.
And that's something that the state authorizes, and
Yes.
the state pays for, but the state pays for in part with federal funds.
In part, it's a federal match. And in fact, one of the issues here is CMS doesn't believe that the state is paying for it properly. It's the state match issue, and this has been true for like 20 years, this ongoing controversy of, is there really a state match here to draw down the federal monies? So what Seema Verma and the current CMS leadership is saying with this proposed rule is, we think supplemental payments nationally are growing way too fast, eating up the Medicaid budget, number one. Number two, we think a number of states are finding ways to draw down federal money without a true state match, which is why this is referred to as a fiscal accountability rule. It's designed to, from the CMS perspective, make the whole transaction more transparent. Where is that state match? What is that state match? So impacts, if I can just go into a couple of impacts. We first of all have the new CalAIM initiative, which is designed, it's very complex, very far-reaching. It's designed to create this movement to managed care. Many of these managed care, some number of these managed care payments under the new CalAIM system are going to be in the form of supplemental payments. The state wants to expand the use of supplemental payments in CalAIM. Now we have a new rule which says, wait a second, maybe yes, maybe no. We're going to have new transparency rules, new accountability rules. So that will be a complication the state will have to work through. The draft rule itself is over 200 pages long, just came out yesterday. It'll take a while to fully analyze it. But beyond CalAIM, it's going to have a bigger impact on hospital financing in California, and it goes to the issue we just talked about a moment ago, Mr. Chairman, and that is the non-federal share. A big piece of how dollars are drawn down in California is through what are called IGTs, intergovernmental transfers. Santa Clara County participates in this, all the major public hospital counties do, and that's where county resources are sent to Sacramento and used, in effect, as the match for the federal dollars. A purpose of this regulation is to review how IGTs are used and to, at least in the quick review that many of us have done of this initial document, to restrict the use of IGTs, to make it more challenging for counties to utilize IGTs and to create this match. So it's going to be a complication for the state of California in terms of not just CalAIM, but hospital financing in general as we enter the year 2020 and this major movement away from our Medicaid waiver into this CalAIM world. So we don't know how big a problem it's going to be yet. 200-page proposed rule just released yesterday. The state, I'm sure, is doing a furious analysis. There'll be all the major stakeholders are starting the analytical process. But I wanted to flag it because it will have an impact on our finances here in Santa Clara County. And a final issue, and then I'm happy to respond to questions that just worth noting.
Before you go to that final
Sure,
issue, I
sure.
don't want to lose the train.
Sure.
I'm assuming that if there's a 200-page rule, that there's a comment period for the 200-page
There'll be a
proposal.
60-day comment period, correct.
And I'm just going to look to Dr. Smith and to County Council and say, look forward to hearing. In fact, we'll make it a formal request. Could we please hear from you off agenda about how you think we should respond? And we'll just.
Yes.
Okay. Thank you.
Surely will.
Just wanted to get that into the record. Thanks.
That's fair. And again, the announcement yesterday was a notice of intent to file it in the Federal Register. I don't know if that's happened yet or not, but the moment they do that, it's 60 days for comment.
Okay.
And the final issue is a change in state health leadership. We talked a few months back about the Director of Healthcare Services leaving. This last week, Mary Cantwell, the long-serving Director of the Medicaid program, announced she'd be leaving as of January. Mary Cantwell, who's very well respected in Sacramento, her departure, along with Jennifer Kent, has implications for CalAIM. They were the architects of CalAIM. Who replaces Mary Cantwell will be a consequential decision by Governor Newsom, and we'll learn about that decision, learn about who that person is sometime between now and January. Just wanted to flag that final issue.
Thank you very much.
Thank you.
Dr. Smith, your microphone's still on. Anything from you?
I'm just expecting you to ask me, given the new rule, what should we be doing to prepare financially for it?
Well, I think that may be a premature question even by my early standards, which is
okay. Well, I'm just ready.
All right. That's good. That's good. That's good to know.
Ready, willing, and able.
But I mean, Ms. Margolis, I inferred, so I'm checking in to make sure my inference was a correct one from what you said, that while there may be room for critique and or improvement in connection with the supplemental payments process, that to simply push the supplemental payment process to the side of the road would preclude a lot of very good efforts from being funded. Did I get that right in your judgment?
And I think even Seema Verma, who's the author of this rule, would probably agree with that sentiment. She's not saying she wants to push them totally to the side of the road. She wants to make those programs, these supplemental payment programs, more transparent. That's her argument. But she also is not especially concerned about them becoming smaller as a consequence. In California, which operates, it's a very complex program, but it operates it with the right intent, which is to fund these services and improve the quality of the system. California will have to struggle now with how to implement this and not make supplemental payment programs diminish to the point where services are impacted. It's going to be a challenge for the state.
Got it. Supervisor Ellenberg, other comments or questions at this time? None. Dr. Smith, you can hold that thought until the...
I'm ready whenever you ask the
question.
Well,
I'm just thinking you've got 60 days to respond, so ho, 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 and Merry Christmas, Happy Hanukkah, and Happy New Year to us all as we go through all that. The timing's ironic at best. And we'll hear a little bit more about this at the next meeting, which is in the first week and a half, I think, of December, when we hope to see you again. So we'll know a little bit more about what's developed then, and I may lean in at that point and ask the same question. Anything else from you, Mr. Margolis?
Nothing else.
All right. Then I believe, as we look down the row, that completes item number 8, which is the final item not on the consent calendar. Without objection and hearing none, we are adjourned. Thank you all very much. Been a productive day.